Good morning, everyone. Welcome to the first annual Patient Conference, ACC Conference. I say annual because I believe this is the first of more to come. My name is Pat Fleet, and I'm an 8-year ACC survivor. I've been very fortunate to have had access to the very best care since my diagnosis. I'm passionate about helping everyone diagnosed with ACC to have the care that I received. I certainly have had my bumps along the way, but having a strong support system has made a big difference in my life. If you take nothing else away from today, I hope you understand there are very caring experts out there that will help you fight your fight. We've gathered what I consider most of the top experts. I want to thank each one of them for their time that they're giving today. They each offer something different, and that gives us all hope. ACC is a tough cancer, and there are so many unknowns, and it affects everyone so differently. I would now like to thank the team that has put this conference together. Emerald Cromwell, Shannon Icon, Darlene Schwab, Amanda Fleet. Also, an extra thank you to Dr. Del Rivero for her advice and help when we were stuck. You're going to hear from all of them later. Now I'd like to introduce you to Amanda Fleet. She is my youngest daughter and caregiver. Last year, she decided that she also wanted to help others navigate ACC and started ACC Connections. She has interviews with doctors on her YouTube channel and will continue to add to it. I'm going to turn the program over to her now, and she will give you more information. Thank you.
Hi, everyone. Welcome. I'm so happy you all are here. So I have a couple of housekeeping things before we get started. So, of course, the disclaimer, please remember that the information presented today is meant for educational purposes and is not meant to be taken as medical advice for your situation. Please see your medical provider for advice specific to your situation. Now that we've covered that, basic things, please subscribe to our YouTube channel and check out our link tree for more information on ACC Connections. Both are linked in the description. It's a work in progress, but we are hoping to provide more resources soon. Check back often. As far as questions, so we've been collecting questions from all of you for the last few weeks. We will also take a few from the chats if time allows. Even if we're not able to get to your questions, we will take note of what's being asked so that we can see what we can plan for in the future and see what's needed and what information you're looking for. So hopefully this will be a good resource for us to get ideas for the future. Just so you know, the team will be monitoring the chat as well to pass along relevant links and make sure that you guys are, kind of get what you need from this. So that's all the housekeeping. So before we start the conference proper, we have a video that was put together by Emerald Cromwell and Paige Cromwell of patient interviews and stories, and we hope you enjoy. So I'm going to switch over to that.
My name is Danielle.
My name is Velvet Lamb.
My husband's name was Mike.
My name is Hope Law.
My name is Shannon Fritch.
Lori Hogg.
George Gurman.
Sarah Viersen.
Shannon.
Sherry Usselman.
So my name is Kay Foryach. I'm from Livermore, California, which is Northern California, about an hour and a half east of San Francisco. I was diagnosed officially December 21st, 2014.
He was officially diagnosed in April of 2020.
July 18th of 2016.
Last year in October.
The fall of 2021.
I was diagnosed with ACC in December of 2015. I was diagnosed at stage 4.
Stage 2 at the time.
And I was stage 2.
They staged me at 3.
And I was stage 2.
I am now stage 4 though.
I'm stage 4.
I noticed that I had this pimple, right on my jawline. I thought, this is so strange.
Well, first I just didn't feel like myself.
And say, oh, today I had a nosebleed. Well, that's weird. Or today I'm dizzy. Or today my blood pressure's up. Or today my ankles are swelling. Or they have been for 3 years.
My hairline was slowly receding, and I did know or notice that I was getting all these chin hairs, be taking them out, and then my voice was slowly deepening.
Just hot flashes, like so intense.
Unexplained high blood pressure.
My daughter and I were at Outback having lunch. He said, "Dad, you don't look good." I said, "That's normal for me."
One day I had some abdominal pain and I was going to head out for the day. And my daughter, who was 15 at the time, had this just real strong feeling that I need to go in, but I did not.
My menstrual cycle came on the 4th, and then again.
The moon phase, extremely high blood pressure, the anxiety.
I had joint pain really bad. I had knee pain, swelling.
I, at the time, had more testosterone than even my husband.
And he continued to have edema in his leg.
So I was struggling losing weight.
Getting body hair, and maybe I was putting on a bit of weight, but you never know because I was going through the menopause. So
Right. But I was 49 when I was diagnosed, almost 50. So I just thought, oh, I'm going through menopause.
I mean, I am about to turn 39 in 4 days. Maybe this is perimenopause, right?
And she looked at me and said, "You're going through menopause. You're going through menopause before I am."
It was a bad timing also in my age. And so I equated a few things possibly to premenopause. To try to be of a community that is trying to dive in and know more.
But I do believe that it's important to see an expert because it's so rare. And, there's not a ton of research that's been done. It's not one of those cancers where everybody's researching and there's a lot of funding.
We have this ultra rare disease.
And at the end of the day, with this type of cancer, you need a specialist. We need specialists that specialize in adrenal cancer specifically. And I have seen probably 3 or 4 oncologists through this. And I remember one said, "There's nothing I can do for you. I have not seen an adrenal cancer patient in 18 years. All I can do for you is support you mentally, emotionally." He said, "But I can't treat you. I don't know what to do with you. You're an anomaly." And I thought, okay, well, I better go find somebody who can.
I don't think there's any other options because it's so rare.
I talked to Dr. Hernandez when we were at NIH for my surgery, and I said, he had this needle biopsy and I've been beating myself up about it. And he said, "Well, you have to go from where you are."
I've been told 3 times.
We're having some technical difficulties. Give me 1 second. Put that here. In a second.
out the ability of my other adrenal gland.
Way to see an expert because
learning about this, and other doctors that do not treat ACC are going to get to become aware of what this disease is like.
I wish I knew right away to see an expert because while my surgeon was great, he at the time was not an expert. I don't know if he would be considered one now. And I remember leading up to surgery, he wanted to do it laparoscopically.
I did not realize that my tumor, which was hormone producing, would knock out the ability of my other adrenal gland to function. And because of that, no one really understands the importance of adrenal glands.
But that's one thing I wish I knew is that just be persistent. If you don't get the answer you want, go someplace else.
Just be a great advocate for yourself.
And I wish that I had known then to look for other patients.
I wish there was somebody to walk me through even the emotional end. If you don't have the hope, then you might as well not even have treatment. And I wish I knew just to take a deep breath and look at all my options before I just jumped.
You can fight this and you can beat it.
I wish that we had had more conversations, more hard conversations. I know it's hard. I know it's painful. I know nobody wants to think about it, but he told me about 2.5 weeks before he died what he wanted done with his ashes. As strange as it sounds, it was really valuable to know what he wanted and to be able to give that to him.
I wish I knew honestly how aggressive this cancer is, and I wish I had more people to talk to.
That I would have understood that life's not promised, for one. And we're not all guaranteed forever. I mean, I don't know from a medical standpoint what I could have done more, but I just, I think I read something online that said it was like a post or something, and it was basically saying we all live as though we're guaranteed 90 years, like the government owes us 90 years or something. It's a birthright. And
Right.
we're not. So for me, that's just, I wish that I would have taken every moment in time, slower, because I miss the old life that I had, the life before this.
And it's a new way of life, right? It is.
Yeah.
And I promise you will get there, and you're so early in your diagnosis, but you are going to move through this is an early stage of grief, and it is loss. You're experiencing loss right now. Mm-hmm. So all of this is totally normal, and know that we are here for you. We are your cheerleaders. We are your advocates. We will always be here to hold your hand. You need to vent, you need to cry, call us.
Since I've been diagnosed, I live my life completely different. And it's because of the people I met in my support group.
Right.
Everything I know is from my fellow patients. Everything.
I'm so thankful everybody in the ACC community does. There's so much wonderful things that we have been able to bring forth. A new friend of mine, her mom was recently diagnosed. And I remember she texted me and she said, "What do we do?" And I said, "Hold on, I'll get right back to you." We in the ACC community said, "Here's the physicians, contact this person, do this, do now, do not wait."
Right.
Here, and here. Was able to provide them so much information, so many more choices than I feel like I had.
My relationship with the support groups, in the beginning, I was obsessed with them, checking them constantly, reading back as far as I could just to get as much information as I could. But I realized quickly that was completely unhealthy because I was obsessed. Since then, I have a love-hate relationship with them. I love getting on there and helping people because I've gained so much knowledge in the last 6-7 years. that I didn't have when I was first diagnosed. And I love being able to share that knowledge and help other people and encourage them to find better doctors and do the things they need to do in order to get the best care. But then on the downside, there's so much negativity, and then there's so many deaths, and it messes with your head, and I need to step away sometimes and take a break.
And I had already asked for approval to get into this Facebook group. And I'm like, Dad, I wish you were still alive so you could help me figure this out. I don't know what to do. And I'm just sitting there crying. And then the next day, I get the welcome to the group, and everybody's welcoming me on. And then this one guy says, welcome. How do you know so-and-so? And he named my brother. Like, that's my brother. How do you know him? And he said, well, I don't know him, but I knew Bernie, who was my dad.
Just surround yourself with the community too. Like, I could never have even found Dr. Hammer or got to where I was if I had not found like the Facebook group.
And a couple people have said to me, you don't have to stay here. And I understand that, but if I can help somebody else, then that makes a little bit of a difference. It makes it better.
The support group, I don't know how I would even be functioning without it. So I'm so grateful for this group. And it really, I'm not just saying it, I truly believe like I would be lost without it, because, you only get, an hour with the doctor, and then you can call them if you have a question, but like the emotional part, or, hey, did you, even just reading people's stories for me is like really, it gives me hope, and it makes me feel like I have a fighting chance.
It's a great resource because you get to meet so many people that have been where you have been.
The doctor who told me was in a hurry because it was Christmas. It was December 23rd. And I said, I don't know what that means. And he said, it means you have about 90 days to get your affairs in order. And he walked out of the room. That was 8 years ago.
I've gotten to be in this journey a year and a few months later with, no chemo, no radiation. So I'm a different story already, and we all are going to have a different journey through this.
I may have ACC, but ACC doesn't have me.
I've got to live. I'm going to live.
And if you hear the word no, don't stop.
That we're not just some people to be swept under the rug.
If you think about it, I was diagnosed October of 2012. I've had my 10-year anniversary, and there's not a whole lot of people who can say that.
I'm not going to be a statistic.
I had so many amazing nurses and surgeons, and I think about all of the people that it took to get me here, and it's overwhelming. There were so many amazing people.
Thank Professor Schembri was Mayor, Pierre, my friend, Adrian Vella, VELLA at Mayo. I thank even now Desiree, because she is being very thorough. Professor Arlt, A-R-L-T, difficult to pronounce, and her team.
Well, my mother's name is Ginger Usselman. True thank you for being there for every step of this journey and just supportive. The prayer team at my CCV church, both are all individuals involved with that group and those that prayed with me in the days up and coming to the surgery. I'm very thankful for Dr. Narula.
I want to give the biggest thanks in the world to Dr. Fojo and Dr. Del Rivero. I love you both so much. I would not be here without the two of you, nor would I be able to live the life that I live without the two of you.
Definitely my biggest thank you to Dr. Edwards, who's my friend that diagnosed it right away. Because I wouldn't be here if it weren't for him saying, you don't need a biopsy. to thank, Dr. Hammer for meeting me and his whole team. They were fabulous. Thank Dr. Fojo for meeting with me over the phone and giving me the answer to what was in my gut, but I didn't know what that was.
Jeannie Snyder was the person that first led me through everything and walked me through everything. And then I'm going to get emotional, but my dear Tina, she was diagnosed a month after me, and she's had an extremely hard journey too. And we have walked this journey side by side and through COVID, and but Tina Rubin is just become one of my best friends. And then Dr. Hammer, of course, because he's just been miraculous.
I'd like to thank Dr. Del Riviera, Dr. Mary Beth Hughes, Dr. Fojo, and last but certainly not least, Dr. Hernandez.
Dr. Hernandez's research nurse, Kathleen, has been wonderful. She was a tremendous support through Mike's illness and, leading up to his death. Yeah. I hope that they know how I feel about them.
Friends that have fought the battle and lost. So they're the ones that are the true heroes. So they took, the chemos that have made it better for you guys, the doctors that spend all their time doing the research. And then, our family and friends. I have a family in Maryland that takes care of me when I come out there. So their name's Carol and Frank, and their stepmom, Marie.
So I want to thank my mom. She's my rock. My stepmom, who literally slept in the bed with me for weeks. And I was like, I went back to baby mode, and she was there, and she's still there for me and my dad. I love them, and I really couldn't do this without them.
And they can make a lot more money doing other things than doing.
Sure.
Let me put it that way. And they dedicate their life to this, which I find admirable. And it's and I appreciate it very much. I really do.
I appreciate every single member that is on our group. If I did not have that outlet of people that get it.
Yeah. Oh, yeah.
Totally different. It would be such a different experience.
Thank everybody who stood by me, who encouraged me, who was just such an amazing part of my care team. My husband, Eric, my sons, Alex and Tyler, my mom, Grace, my dad, Mel, my cousins, my friends, my friend who said, you have to go to the different doctor because you need some help. Thank you, Diana, for helping to save my life. Diana and Linda for going to the oncologist with me because it seems so surreal. To my aunts, to my uncles, to my family, my kids, to my physicians who listened to me, to my coworkers who picked me up and drove me to work. There's so many things and so many people to thank, and not one of them is less or more important than the other, and all of them I cherish. And I'm so eternally grateful. Thank you so very, very much.
Sorry about the technical difficulties, but I think we've got everything straightened out. Thank you so much. So now I would like to introduce Dr. Julie Hallanger Johnson of Moffit Cancer Center. She's going to be doing an introduction to ACC, and I'm going to turn it over to her.
Thank you very much, Amanda. Let's see. I can get my screen to work here. I'm trying to share my screen, so I may be challenged as well. Let's see. All right. Hopefully you're able to see that. First of all, I just want to thank all of you for this opportunity. And it is a very hard act to follow that video. Those are heartfelt things that we see every day, and we feel with you. And sometimes, some of us are better at walking that journey with you than others. I hope to be one of those people that's there to listen and to help when we can. This, I feel kind of silly giving an introduction to adrenal cancer to all of you who need no introduction and probably wish you had never been introduced. I'm going to walk through just a few brief things, and hopefully you will be able to follow along. Okay. So I do serve as a consultant for HRA Pharma, along with many other people who work together to try to improve the outcomes for people with ACC. I want to dedicate this to my favorite 1 in a million patients. We're here because of you, and thank you for what you teach us, and thank you for helping us to advance the science for cures and improved options to treat this disease. This is a group of patients organized almost entirely by Emerald Cromwell. This is a memorial walk for Shannon. And so this was from pre-pandemic times, the last time. And this group has raised a lot of funding to help our research and further the advancement. And this is a joy to celebrate with this group. I'm just going to briefly go over several things. Many of the other speakers will cover in greater detail particularly mitotane and other approaches to treatment. But I just wanted to review for all of you where the adrenal lives. These are small glands that sit just above the kidneys. They have essentially 4 layers. There are multiple different hormones, precursors and metabolites of these hormones. But essentially the layers outside the adrenaline layer are what are the tissues involved in adrenocortical carcinoma. The center of the adrenal produces adrenaline, and those tumors are called pheochromocytomas, which are a completely different subset of adrenal tumors. So the 3 layers of the adrenal cortex produce, essentially in medical school, they teach us salt, sugar, and sex. So salt hormone, which is aldosterone, sugar, which is the cortisol and stress hormone, and sex hormones called DHEA sulfate. So they were initially described anatomically in the 1500s, although if you read even further dating back, there are some descriptive terms that even in the Bible describing the fat that sits in the back of the body. When Addison was working and patients had a lot of tuberculosis, he described symptoms of adrenal insufficiency, which is why primary adrenal insufficiency is called Addison's disease, if it is an autoimmune type. And then other researchers found that if they took the adrenal glands out of animals, the animals died. So they found, and over time, the understanding of the hormonal production was really led by research into inborn errors of adrenal metabolism, showing what happens to people who have too much or too little of various hormones. So how are adrenal lesions overall are found relatively commonly. And if we have a patient that shows up in the emergency room with abdominal pain, maybe as many as 8% of us will have an adrenal lump or a bump. But in patients with high blood pressure, it's even more common. And if you just do screening studies on healthy patients, it's much less common. It does increase in incidence over our ages, almost equal in men and women. And most of the time, these are benign findings. So you could have an adenoma, you could have nodular hyperplasia, or other benign fatty lesions or cysts. Adrenal cancers are much less common, and you can see metastatic disease to the adrenal gland or adrenaline-producing tumors called pheochromocytomas. So what are adrenal lesions and how do we approach them? You know, the minority of adrenal lesions are cancerous, but up to 8.6% of incidental nodules are malignant, so it isn't something that we wish to ignore. ACC is only 0.3% of all adrenal tumors, and 60% of those are functional, meaning they are overproducing some type of hormone. Metastatic disease to the adrenal is common, particularly for someone like me who works in a cancer center. And if you look at patients with another type of cancer, 43% of adrenal masses in that group are going to be metastatic disease. So at Moffit, we do have an adrenal nodule pathway that is available to our team members so that we are able to make certain that we're doing the appropriate evaluation of lumps and bumps in the adrenal gland. Irina Bancos and many others, she's from Mayo Clinic. She has done a lot of research in looking at urine multisteroid profiling to try and better characterize these adrenal lesions. And I think that over time, that's only going to get better and better. I've also been a part of a group called the Global Society for Rare GU Tumors. This is a urologic group, mainly urologists involved in this. And we put together this website, which is available to anyone. You can read over how to work up the adrenal lumps and bumps. So that's more of a public side of how to work up adrenal lumps and bumps. These are the other people that I'm privileged to work with on that group. And the idea behind this is to make certain that people understand how to manage these tumors. So this is kind of making sure that we're getting the word out about how to evaluate and treat tumors of the adrenal. And this will include hormonal assessment, discussions about biopsy, all the different resources and treatments, and particularly for surgeons so they understand. And then there's a nice prescription for the lab testing and instructions for adrenal testing. So how do we know if an adrenal lump or a bump is an ACC? Sometimes it's because of the size. Sometimes it's because of the hormonal symptoms. Sometimes it's because people present to the emergency room with pain and we find a big mass. So many of these do have hormonal production, cortisol, androgen levels. There are rare estrogen producing tumors that, so there are all sorts of different hormones that we measure to try and characterize better and to give us a marker to follow as well. So the larger the adrenal lump or a bump, the higher the risk is for adrenal cancer. Although any lump or a bump over 4 centimeters is often not cancer, we do recommend removal of adrenal lesions once they reach that size because of the risk for malignancy. So our group published this evaluation of the National Cancer Database for patients with ACC. What it was is looking to see if biopsy diagnoses impact the outcomes. We wanted to make sure that this was public knowledge and to try to make sure that people understand that if you do a biopsy, that it actually upstages the disease. So we're just trying to get the word out about trying to remove things when they can be removed and to not do a biopsy. Of course, this was a reasonably small group of patients that did have a biopsy, but what we noticed, and I want to introduce you to your first Kaplan-Meier curve of the day. This is called a survival curve, and you can see along the bottom axis that these are survival in months, so the time frame. And over time, what you would like to see is to have everyone a straight line across the top, because that means everybody lives forever. And what we do see is that if you have a clinical diagnosis, you do better than if you had a biopsy. And so these are things that we just want to make sure that we get out there to share with the public. So as you all know, about 1 person per million, that's why I call you all 1 in a million. The median age is about 55, although younger patients, the pediatric patients with Leigh-Fraumeni syndrome tend to be the ones who get it at younger in age. 70% of patients do present with advanced disease. And the 5-year survival varies depending on which registry that you read. We also know that surgery is the best treatment for 2nd, 3rd, and 5th. We want to do a hormonal assessment prior so we know what to expect postoperatively. I think what the comparison between the bottom 2 numbers, which is the retrospective analysis at the University of Michigan versus the SEER. So the SEER is a database that this particular database covers about just under half of patients in the US. And so what I think this points out is that if you have a multidisciplinary team approach, you're more likely to do better. And I think that, you know, you've all discussed that in your videos, and I think that probably goes without saying, which gives me the opportunity to recognize the amazing team that I have the privilege of working with at Moffit Cancer Center. Definitely wouldn't be here talking to you today if it wasn't for the strong team that we work with. So if you're able to have surgery, definitely we think that that's better than if you're not able to have surgery. And I think that probably goes without saying that more advanced patients aren't able to undergo surgery for multiple reasons. So we already mentioned a little bit, why do people get ACC? Genetic underpinnings are sometimes present. Lynch syndrome is another one that I didn't place on the list, but there are multiple mutations that we consider both in your own genes, but also the genes of the tumor. And so when we say somatic mutations, that means the tumor genes. And so there are multiple different genes that have been looked at. And the TCGA is the Cancer Genomic Atlas, and that's been looked at for ACC, and those are the major players that have been found in that group. So the staging, this is the most recent updated staging, which is AJCC 8th edition, and this is much more similar to the staging that the European groups use. So you can see that if you don't have metastatic disease, you're anywhere from a stage 1 to a stage 3. But if you have distant metastatic disease, that's where the stage 4 comes in, various sizing of the tumors. So this is how we stage tumors. We think about how big the primary tumor is. Does it involve lymph nodes? And are there metastases far from the tumor itself? So this is how we kind of speak the medical language to each other, and I know you all mentioned that as well. So what are prognostic factors? I think that, you know, the stage is important, as we have already shown, but it's also important to talk about the grade. Now, what is the difference between the stage and the grade? The stage is, as I mentioned, the size of the tumor, lymph node involvement, whether metastatic disease is present, and the grade is under the microscope. So when the pathologist looks under the microscope and can tell us, you know, how quickly is this tumor growing, how rapidly is it dividing based on some factors, including the number of dividing cells, call that mitosis, as well as a feature of a proliferation called the Ki-67, which is a stain. And so those are ways that we talk to each other about evaluating the tumor and deciding on what the next steps are. So If you have microscopically negative margins, that's definitely better than if you have a little bit of positive margins from the microscope, or if it's grossly extending into soft tissue, etc. We do generally recommend an open resection for tumors like this because that avoids the tumor rupture and seeding of the tumor along, for example, a laparoscopic resection. So that's something that we talk about. We talk about whether cortisol is produced, because cortisol production, actually those tumors tend to make the immune system that naturally tries to fight the tumor. We think that the cortisol production probably impacts the immune system to the point that the immune system can't fight the cancer to the same degree. So there are medicines that we use to block cortisol production, including mitotane, which you'll hear about in the next session. So we also think about, is it invading into vessels? Is it growing so fast that it's necrosing or dying on the center? Is it, I mentioned, dividing rapidly, that high mitotic rate, or atypical mitosis? And then some other expressions of certain things that we, again, can stain for on the tumor, on the tumor itself. So one of the things that we've considered, and this is a very small study that came out from MD Anderson some years ago, which is the use of neoadjuvant or chemo before surgery. And this was a study, a very small number of studies, like many, unfortunately, like many studies in ACC. These were patients who had what was deemed borderline resectable, so meaning the tumors invading the liver or the kidney or the spleen or the pancreas, and all of those structures would need to be removed. Or if there was tumor thrombus, where the adrenal tumor has grown into the adrenal vein and sometimes into the inferior vena cava. So when we have those kind of situations, this study came about showing that perhaps using chemo before surgery might be something to consider. I will say that we don't always do this, but it is something that our team has considered. I think we need more data to understand fully this, but it did show that in these patients, in these 13 patients who received chemo before surgery, they did have an improved disease-free survival, as you can see at the arrow. Now, when we do the resection, and I say we, meaning the team, I'm not a surgeon, so this is indicated for stage 1 to 3 if it's feasible, sometimes stage 4 as well, and it's done open. We want to achieve, our goal is to achieve an R0 resection. So what does that mean? That means that all the disease has been removed from the surgeon side, removed it all, and on the pathology side, all of it is, the margins are clear. We want to avoid rupture of the tumor and seeding. And obviously, that's why we recommend an open approach rather than a laparoscopic approach. And then some patients who have tumor thrombus, particularly extensive tumor thrombus, may need a cardiopulmonary bypass operation. I think it's very, very important to just highlight adrenal insufficiency. Adrenal insufficiency can be life-threatening. It is something that we often deal with, particularly in our patients on mitotane. But even if you have an adrenal tumor that's cortisol producing, that's completely resected and it's low grade and it's not causing any, it's not going to require mitotane, those patients often will have the other adrenal gland that's sleeping. And so post-operatively, we need to monitor for that. And we need to treat that immediately when it happens so that patients can recover well. And this is something that probably, I would say our nurse practitioners and PAs in our team spend a lot of time, educating patients and making certain that our patients are doing all of this very well, and our nursing staff. You should have a medical alert bracelet or jewelry of some type, or get a tattoo if that's the way you prefer it. At minimum, you should have a card in your wallet that says that you're adrenally insufficient. You need to have that emergency steroid kit, whether it's Solu-Cortef or dexamethasone, that you have it with you when you travel, when you go anywhere, that you take it with you. And then typically we use hydrocortisone to replace adrenal insufficiency. And the usual doses for those of you on mitotane do not apply, because the mitotane just chews through that steroid. We need much higher doses. The higher your mitotane level is, the more hydrocortisone you need. This is why we need to frequently monitor you. And again, I'm sure the next session they're going to go over this in greater detail. So in patients with history of Cushing's, meaning cortisol production, again, physiologic replacement sometimes feels like it's not enough. So occasionally we have to start high and kind of bring them down to a more normal dose. I think the European Society of Endocrinology is wise. They've developed these kind of standardized cards that they want people to have in their wallets and that sort of thing. And these, I think, are helpful. If you can download these yourself, you don't need a prescription for this. You just download them off the internet and print them and at least have them in your wallet. So if you're in the emergency room, you just hand it to your doctor. And then the one on the right is for pediatric patients, so that they can understand the differences in dosing for the pediatric age group. And again, the hydrocortisone doses sometimes need to be done more often in people on mitotane. So I'm going to briefly talk about this, but I don't want to upstage Dr. Kiseljak. And so this is just the first paper that came out using mitotane. It was in the 1960s. So this medication was discovered because it's a relative of the insecticide DDT, which was used. Unfortunately, dogs exposed to it had adrenal atrophy. And so they found this and decided to capitalize on it. It's a challenging medication, as you all know. It destroys adrenal tissue, which is why we use it. It often is more effective, particularly in patients who have hyperfunction of the adrenal tissue. So cortisol production, androgen production, it's very helpful in that regard. Also destroys adrenal tissue, so that's what we want. It does cause adrenal insufficiency because it destroys the adrenal tissue. It can cause all these other changes that I'll leave for the next speaker. And when to use it. This is another one of those Kaplan-Meier curves that I mentioned. Again, this was the study that really, again, a retrospective, non-randomized study, which we want a little bit of a different kind of level of evidence. But in this group, what they found was that the group that received mitotane did better. And this was a systematic review and meta-analysis showing that it trended towards a decrease in recurrence-free survival. Overall survival, I think that's a little bit of a jump, because most of those, were not necessarily statistically significant. But in any event, these are how we decide. So a hazard ratio means that is it helpful or harmful? Does it help reduce recurrence rates, et cetera? And so you can see each of the studies here go along this line. And if it crosses 1, that means that it doesn't help or hurt. It's just kind of neutral. So you can see that if you put all of this data together, it trends here, but that's because of this one study showing that it did better. So there was a study called the Adjuovo trial, and this was a trial in patients who had low-risk ACC, and low-risk ACC patients were included if they were stage 1 to 3 and a low Ki-67, so that proliferation rate, and they had to not have evidence for residual disease and be less than 3 months from their surgery. And so they randomized these patients 1-to-1. So one group received mitotane and the other group just received observation. And they were targeted to try to get the mitotane levels above 14. And these patients, I like this. This is 91 patients were studied, and patients at a low to intermediate risk of recurrence after surgery are a minority. However, they show a far better prognosis than expected and do not benefit significantly from adjuvant mitotane. So this is nice for us to know that low risk patients don't need mitotane. This, the study, the physicians who did the study also mentioned that it wasn't powered enough to decide this for our stage 3 patients, but hopefully we continue to get more information. We do use adjuvant radiation for various patients. I realize I'm running out of time here. Apologize. So I'll just be quick to go over the last few slides, which is showing radiation. These are 2 different studies. The one with the on the right is from the University of Michigan, showing that recurrence-free survival was improved, but not overall survival. And then also the bottom was an additional study looking at 1,184 patients in a database showing that radiation may trend towards improving outcomes. All right. And then this is the study showing combination chemotherapy in advanced ACC. So this was from 2012, and this was the study called the Pharma trial, which is what we base the use of mitotane plus etoposide, doxorubicin, and cisplatin on. Again, my goal is to see an improved response from 23%, but that is where we are. So what are our future directions? In my opinion, I think some of the future directions, which hopefully my colleagues can speak to even more in detail, but I think cell therapy is one of the things, particularly at Moffit, that we're excited about the potential for in solid tumors. So these are therapies that essentially engineer your lymphocytes to fight your cancer. And so this is done in various ways, which I won't get into, but I think that is where we're headed. And these are pictures of Moffit, and where I'm privileged to spend my time. And again, I just wanted to thank you for this opportunity.
Oh, let me turn my camera. Thank you so much, Dr. Hallanger Johnson. So we are going to move to our next session because we're a little bit behind. So I am going to pass the baton to Dr. Jaydira del Rivero, who is works at the National Cancer Institute at NIH. So.
Right. Hi. Thank you so much, Amanda, and welcome everyone today. We're really excited of this conference. And as Julie Hallanger also mentioned earlier, this is a dedication to you all as a patient, as a caregiver. And as I say, many of you physicians that study this tumor type, and you are our passion, our motivation every day. So this is for you, and please feel free to ask any questions at any time. And if you have any questions, even after the conference, you can always reach out to any of us. So thank you so much for giving us the opportunity to be with you all today. And with that, I would like to introduce the first speaker. Our first speaker is Dr. Katja Kiseljak-Vassiliades. She's a board-certified endocrinologist, and she's currently an associate professor at University of Colorado. She has a focus on adrenocortical carcinoma. She was the one who generated the first adrenocortical carcinoma cell lines, as well as patient-derived organoids. And later on, we are going to explain what is that and why that is very important for research. And the idea is to be able to develop novel therapies for this tumor type. She's going to speak to you today about mitotin treatment as well as mitotin side effects. And with that, please, Dr. Kiseljak-Vassiliades.
Thanks, Dr. De Oliveira. Let me see if I can share the screen here. All right. Let's see. Okay, so I hope you can see my screen. And I'm so glad to be here today, and I'm so excited that the ACC community has organized this conference, and I'm thankful that they invited me to talk. So I'm going to be talking about a mitotin treatment, and we'll just talk a little bit about who should get it, when, how long, and about some of the side effects. Some of the slides might be a little bit repetitive from Dr. Johnson's talk, but I think that it's good to hear some of the things a few times to kind of really get it. I'm at the University of Colorado in the division of endocrinology, and just a little sort of a side story. Our University of Colorado has really started to get interested in adrenal cancer in patients about 11 years ago, and the main reason was that we really had several patients that came to us and said, we wanted to come here and be able to live in Colorado or surrounding states and being able to be treated here. And so we got interested, started the clinical care. Dr. Haber and Dr. Hammer have both shared a lot of protocols with us. And then got interested in research because we wanted to improve the treatments. We wanted to make sure that we can get patients new treatments because the current treatments are okay, but they can be better. So today we'll talk about mitotin. I am also an advisory board member at the HRA Pharma, and I also was at the advisory board meeting for Pfizer. So these are the objectives. I'll give a brief overview of mitotin and how it became FDA approved. We'll talk a little bit about mechanisms of mitotin, about who should get it and how long, and then some of the adverse reactions, some of the side effects that are associated with mitotin and how to treat those. So what is mitotin? A lot of you have heard of mitotin, and a lot of you, probably most of you, are on mitotin. And you probably heard that mitotin is a derivative of insecticide, DDT. And here is the long name of what DDT really means. And I just wanted to give a little bit of backstory because people always ask, what is this? And so DDT was really synthesized in 1874, so in 19th century by Austrian chemist Ottmar Zettler. And it really was not understood what DDT did until actually 20th century by chemist Hermann Muller. And in Second World War, they used DDT against insect-borne illnesses, malaria and typhus. After the war, in 1948, Muller received Nobel Prize in Medicine for discovering of DDT as an insecticide. And eventually, mitotin was derived. And here you can actually see how mitotin is different than its sister compounds. So DDT is here, and you can see DDT has this chloride on the two rings. And mitotin is similar. It has only two chlorides, and then the position of the chloride in this first ring is a little different. So it's a derivative of the DDT, but it's a little bit different. Okay, so what is the role of mitotin in ACC and how this really came about? So in 1948, Nelson and Woodward are two scientists, and they reported that this mitotin, which at that time was called OPDD, has produced adrenal cortical atrophy in dogs. Basically, there were some dogs, they were in some meadows, and they were not doing well. In fact, actually, some of them died. So they sacrificed the dogs and look what's wrong with them. And they found that their adrenal glands were atrophied. And that was a very interesting finding. And then some other investigators, some of them actually published another study, Larson and Haag, in 1955, and they confirmed this study in dogs. And so Dr. Birkenstall, actually, this is posthumous, so he already died at that time. He actually thought that this would be very interesting finding to potentially use in patients. And so he wrote this paper that you just saw also on the previous slide, and he said that oral administration of this mitotin to dogs induced selective necrosis of the zona fasciculata and zona reticularis of the adrenal cortex. I'm just gonna just briefly, I have to answer the phone because it's my ADT security. 1 second. Hello? Interesting, and they wanted to apply it to human, and there was a disease, human disease, adrenocortic carcinoma, that they thought this could be useful for a patient. They initially tried and they were not successful, but the reason they were not successful was probably the dose. So this is the first mitotin study in humans, and there were 18 patients. So these 18 patients are listed here. You can interestingly see that actually in the study, they have patients' initials written in a publication, and this was study published in 1960 in Annals of Internal Medicine. That would never happen today. But regardless, the study was published. They have these patients, and they looked at what happened to these patients if they give them mitotin. At that time, this was many years ago, they actually went all the way up to 10 grams of mitotin in patients, which is much higher doses than we do today. And they saw that a lot of these patients actually had a response. 7 patients had a very good response to mitotin. And then 7 of the patients had a sort of more stable disease, but they had a response to steroids. As you can see, a lot of these patients had Cushing's. And then 4 patients did not have a response. So based on this study and several other case reports, mitotin received an FDA approval in 1970 for use in adrenal cancer. And so really, mitotin has been approved for adrenal cancer for the last 55 years. The question, of course, became like, how does this medication work? And the punchline is that the exact molecular mechanisms of how mitotin works is actually still unknown. What we do know is that mitotin actually works specifically on adrenal glands. So people have looked in other organs and really does not have a lot of effect on other organs, but it works in adrenal cortex. So this is the adrenal, the medulla, and this is the adrenal cortex. So adrenal carcinoma starts in adrenal cortex. And what researchers have found that mitotin inhibits mitochondria. So these are the little organelles in the cells that make energy. So it inhibits mitochondria and then causes selective death of these adrenocortical cells. It also causes decrease in stereogenesis. So we know that that's how mitotin works, but the exact mechanism of how it affects this mitochondria and what exactly it does, even now, 55 years after mitotin has been approved, we don't really understand. It actually is still a part of the active research that we are trying to do, because if we can find out how mitotin exactly works, we can potentially develop medication that could mimic that, have smaller side effects, and be better in the mode of action. So next, who should be on mitotin? And I hear this question a lot of times. So I'm showing here some of the slides that you have already seen before. They just look a little bit different because they're in different publication, and they're summary of several different studies that have done through the history. So here we're looking at how good mitotin is to prevent recurrence. And so post-surgically, you give people mitotin. And here on the left side is if this line does not cross 1, that means it's statistically better. So the treatment with mitotin is better. On the right side, if it does not cross the line, would mean it's statistically worse. So you can see here that quite a few studies actually show that giving mitotin to patients post-operatively, it's actually better. And when they did a meta-analysis, meaning they took all these studies and put them all together, the line is crossed, but it's definitely much more that indicating that the treatment with mitotin is better in preventing recurrence. They also looked at mortality. So this is overall mortality when somebody is given mitotin after surgery. And again, here, left, the treatment is better, and the right, the treatment is not better. So you can see that there's actually none of them that are here, meaning the treatment is not better. And when you look at the meta-analysis and collection of all these different studies, it actually shows that treatment with mitotin post-surgically actually improve survival, because this question was about mortality. So now looking at some of these studies, a lot of these studies are actually from different countries. We have Italy, we have Germany, we have US. So there are different studies, different patients. So when people actually looked, who are these people that actually might derive benefit from mitotin, they really kind of got subdivided by stage. So number one thing you have to know is that randomized prospective clinical data are lacking, and we'll talk a little bit about Jaydira. But overall, looking at the retrospective studies, that means studies that where we just go and look at patients retrospectively, shows really compelling evidence that patients that are initially diagnosed with stage 3 and stage 4 have a compelling evidence that mitotin is associated with increase in recurrence-free survival and overall survival. For stage 1 and 2, and these are patients that are Ki-67 less than 10 and has had gross resection, meaning there is no tumor seen after the surgery, there is really no evidence for mitotin or against. So Jaydira, the Dr. Helga Johnson talked a little bit about, is a study that has been looking at exactly that question. Is there any benefit from mitotin in patients that have stage 1 or stage 2, sort of a low-grade adrenocortical carcinoma? And this study is still ongoing. There have been some preliminary results presented at endocrine society meetings last year and the year before, and really suggest there is some questionable benefit of mitotin in low-grade ACC. But again, you have to remember that most patients are not diagnosed with low-grade ACC. And really, talking about mitotin in this setting is still patient-tailored. Jaydira 2 is a new study that has been also coming up. We're doing it at the University of Colorado. In the primary center is MD Anderson, and the primary lead is Dr. Habra. And here we're looking at the efficacy of chemotherapy together with mitotin in high-risk patients, and that means it will give chemotherapy in high-risk ACC right after surgery to see if there is improved in recurrence-free survival and overall survival. And this trial has started in 2019 and is still ongoing. So here is the algorithm. This was published in 2018, and these are sort of the guidelines, the only guidelines that are published for adrenocortical carcinoma and how to treat. And here I'm circling the mitotin question. So when patient has a resection, if the tumor is low or intermediate risk, you can consider mitotin. In high-risk patients or advanced adrenocortical carcinoma, mitotin is used as adjuvant therapy, meaning post-surgical therapy. So how long should mitotin be continued? This is a very controversial question, and and there is no clear answer. I think the recommendation here in the guidelines published by European Society of Endocrinology is really expert-based, meaning there is really not a lot of data to suggest one way or the other. So in patients without recurrence who can tolerate mitotin, the suggestion is to take mitotin for at least 2 years, but no longer than 5 years. So, the question that I always get, patients that have been on it for 5 or 6 years, and they ask, should I be on it, yes or no? And that's always a discussion. And the reason here is why they say no longer than 5 years, because the thought is if the person has not recurred for 5 years, the risk of recurrence has dropped a lot. However, in the lab and in some of the studies in mice, the issue is that what is mitotin really doing? Is mitotin keeping these cells in check? So I think when we get to 5 years of mitotin, there is a discussion of what should we do? Should we take a holiday? Should we continue the mitotin? I think that's very, very sort of patient and doctor-driven decision. And I think this 5 years might not necessarily be 5 years, especially if the person is tolerating mitotin and they have been doing well. So I think at least for 5 years is good. For no longer than at least 2 years is good. No longer than 5 years is, I think, a little bit of patient-based decision. So when to start mitotin? Most experts, including the guidelines, recommend to start mitotin as soon as possible after surgery. So ideally within 6 weeks as the person heals, and no later than 3 months post-operatively. And how to start? We usually up-titrate. Some people are able to up-titrate it faster. And we really try to target 3 to 6 grams per day. And usually we divide those doses in 2 times a day. So a person will take, for example, 2 or 3 grams in the morning, and then 2 to 3 grams in the evening. In University of Colorado, we really found it helpful to start patients also on proton pump inhibitors and antiemetics with mitotin. And these drugs basically are like Prilosec and Zofran. We usually have patients take it in the morning, and then they take their breakfast, and then mitotin after the breakfast, and the same thing with dinner. And as we find that helps with some of the upset stomach and some nausea. So what are the associated adverse effects? So common are nausea, vomiting. Sometimes people get diarrhea, fatigue, and brain fog. As far as these, as I told you, we try to give people Zofran and Prilosec to help someone with the upset stomach. But you have to also remember that sometimes these nausea and vomiting and fatigue could be related to adrenal insufficiency. So it's very important that when you're getting managed by your oncologist and endocrinologist, those things are considered and proper medication is started. And we'll talk a little bit about that later. And then the less common side effects are memory loss, liver toxicity, bone marrow suppression, and rash. And so to sort of monitor for these are some of the parameters that we monitor usually on every 2 to 3 months basis. And after starting mitotin, a little bit more frequently. So we monitor mitotin level to make sure that they don't become toxic. And the target levels are about 14 to 20. We monitor liver enzymes to make sure people do not develop liver toxicity. And then we monitor the blood counts, that's the white count and the red count, to make sure that there is no bone marrow suppression. So these are monitored usually at every appointment the patient has. And then what about this hormonal adverse effects? So mitotin does affect adrenal gland, and it also affects some other glands in a sort of a different way. So people develop low thyroid, and that's usually from the pituitary more so than the thyroid. There are some reproductive abnormalities, and then high cholesterol. And so things that we monitor, so for the adrenal insufficiency, we monitor ACTH, and sometimes we monitor renin. Those are 2 different hormones, 2 different. So one of them is glucocorticoid, one of them is mineralocorticoid. We monitor thyroid hormones, TSH and 3T4. Cholesterol, and then in men, testosterone and sex hormone binding globulin. So here is a little schematic of why and how mitotin really does this. How does mitotin affect these hormones? So this is a normal physiology. So you have ACTH that is secreted from pituitary. It goes to the adrenal. Adrenal secretes cortisol, and then some cortisol is free cortisol, that's just active cortisol, and then there's cortisol that is bound to this CBG, cortisol binding globulins, which is basically a protein that sort of keeps cortisol not active until it releases. So what does mitotin do? So number one thing, mitotin blocks the effect on the adrenal, so it blocks the effect of cortisol, and cortisol gets less secreted, and because of that, there's less cortisol in the blood, and pituitary sees that, and ACTH increases. The other thing that myotin does, it goes to the liver, and it actually secretes more of this cortisol binding protein, and so the more of the cortisol is bound, and so less of it is free. And so because of that, liver has another effect of myotin, and that's it increases an enzyme that metabolizes cortisol. So when we give people hydrocortisone, for example, there's less cortisol in blood, and then hydrocortisone goes very fast through the liver. And this is why Dr. Johnson talked about you need to give people much more cortisol than usual because cortisol is bound and it goes clear to the liver very fast. So when you have myotin-induced adrenal insufficiency, you have high circulating binding cortisol. You have this liver processing enzyme that increases, and when you replace with hydrocortisone or prednisone, and also fludrocortisone, you have to give people much higher doses to achieve normal level. And then to monitor for this, you monitor ACTH, you can look at the renin, and then some people also monitor the 24-hour free urine cortisol. Very similar story with thyroid, just a little different mechanism. So this is normal. The TSH comes from the pituitary, binds to thyroid. Thyroid secretes thyroid hormone, and then thyroid hormone is bound to this thyroid binding globulin. So this is when it's inactive, and then free thyroid is active. So that's normal. So what happens with myotin? So myotin here does not actually affect the thyroid. It affects the pituitary. And it makes the pituitary TSH go low, and because of that, less TSH goes to thyroid, and so there's less T4 in the blood, so the T4 drops. And then myotin also affects the liver, and it increases the binding globulin, so there's, again, much less thyroid in the blood. And then liver enzyme is high and goes and clears the levothyroxine that doctor gives you much, much faster, similar to hydrocortisone. And so here again, people need to be on much higher doses of levothyroxine than if they just had a failed thyroid, because the globulin is increased and the levothyroxine gets much faster through the liver. So people have what we call central or pituitary hypothyroidism. The TBG protein is high. The increasing processing of levothyroxine is high. And so people get levothyroxine, but again, much higher doses are needed to achieve the normal level. And we monitor T4 and thyroglobulin binding globulin if you do total T4, or you can just monitor free T4. Some people also monitor TSH. So in summary, it's important to remember that myotin is our only post-operatively approved therapy in high-risk ACC, and then in low-risk patients, myotin treatment can be considered. Myotin needs to be started soon after surgery, preferably within 6 weeks, and then continued 2 to 5 years, sometimes longer, in patients without evidence of recurrence. Myotin is associated with nausea and vomiting, and that's common, but adrenal insufficiency needs to be ruled out, and appropriate replacement of hormones needs to be done. And sometimes pre-medication with prilosec and Zofran can be considered to help with the upset stomach and to be able to tolerate myotin. Myotin is associated with hormonal dysregulation. People get adrenal insufficiency, hypothyroidism, and high cholesterol. And so sometimes people are started on cholesterol medications, but most of the time people are going to need hydrocortisone or prednisone, fludrocortisone, and levothyroxine. And these hormones, so the good news is that these hormones can be readily replaced. They're old hormones. They usually don't have a lot of side effects, and so people can deal with this myotin-induced hormonal issues. And with that, I will put a picture of Colorado so you can remember where we're from. And then I think we're going to take some questions at the end of the next presentation.
Thank you so much. Can you hear me, Dr. Kiseljak-Vassiliades? Great. Thank you so much for an excellent talk, really important information. And yes, we're going to ask questions at the end. I would like now to introduce Mrs. Kelly Price. She is the head of U.S. operations and oncology as well, and endocrinology for rare diseases at HRA Pharma. She has over more than 25 years of experience. And over the last decades, one of her goals is to be able to improve patient access of mitotaine in patients with adrenocortical carcinoma. At the same time, she focused as well on empowering patients and those suffering with this disease. And with that, thank you so much, Mrs. Pry, for the opportunity to come and talk to us today. And the floor is yours.
Fantastic. Thank you, Dr. Del Rivero. This has been an incredible talk already. So I just want to say I'm new to the ACC community. I joined HRA in October. I've had the chance to hear from patients, but I have to say that each time I do, it is incredibly touching. My father actually went through rare cancer, and so went through that journey with him at MD Anderson, and that's really what ignited my passion around access and rare. So I'm going to keep it a little brief today. I want everybody to know that the most important thing is to hear from the experts. I am not an expert, so I will leave more time for the physicians and all of the clinical expertise here, but I wanted to go over some of the things that may be important around affordability and access in this space. On the next slide is a disclaimer just to say everything I share today is my own opinions and not a reflection of HRA or their views and opinions. And then on the next slide, you all know, certainly if you're on it, but Alliance, Amanda, yeah, perfect. We'll go through the pharmacy, different types of financial support, some special considerations, laws that have changed and things that may impact you all. And then we'll leave contact information, because if you have specific questions, need help of any kind, I want to ensure that you all know that we are here and you can reach us and we will help you in any and every way that we can. So any questions for us, please feel free to reach out. Like I said, at the end of this session, we will have contact information so that you can get anything that you need from us. Okay, so on the next slide, we're going to talk about Alliance. It's Walgreens for you, of those of you that are familiar. They call themselves Walgreens Alliance in the specialty world. On the next slide, we talk about, so Alliance, Walgreens Alliance is the only specialty pharmacy that carries mitotaine. So that is the only place that you can get it from. Amanda, can we go to the next one? Perfect. It can be sent directly to your home. Some of you may not know, and Emerald and I were talking about this, or you can arrange to have it shipped to a local Walgreens if that's more convenient for you, and then you can pick it up at your local Walgreens. Another key thing I like to say to people, I'm also a nurse, and what some people don't understand is you can actually refill your medication on most insurance plans every 21 days. So if you're worried about running out, or maybe you're traveling or going to be out of town, you can start to refill your medication 21 days after your fill. Alliance is supposed to make sure that you have all your copay assistance has been applied. If you need financial assistance, please raise that to them when you're speaking with them. They will facilitate and help with additional financial assistance if you need it. They will also report any adverse events that they hear from you while talking. And here's their phone number, and we'll also put it on the last slide as well. Okay, so a couple of things on the financial support. There are three main types of financial support, mostly here in the US. I know that there's some international attendees here, even from Tasmania, I think, and I saw the UK. But here are the ones for the US. On the next slide, the first one is copay card. So if you are not a Medicare or Medicaid or government funding, you can get up to $4,000 a year applied to your out-of-pocket cost for mitotaine. You pay the first $80, and then the rest will be covered up to $4,000. Keep in mind that the manufacturer can change this at any time, hopefully for the better, but sometimes can make changes at any time. One thing, we're in January now, so just so everybody's aware, if you have a deductible, it can be reset typically at 2 times during the year, January and June. If you have an accumulator on your insurance, a copay card accumulator, that means any financial assistance that we provide as a manufacturer does not apply to your deductible. I bring this up because we are fighting this very furiously. We have banned it in 13 states so far. We are looking to ban it at a federal level because ultimately this means that the insurance company will take the financial support and you do not benefit from it. And it should be applied towards your deductible, so you don't have to pay your deductible plus this. And so we're working on that. There's also a maximizer program that aims to do some of the same thing, which is not let you all benefit as patients from the financial assistance that's provided by the manufacturer. The center section is foundation support. So this is interesting. Another thing that we're really working hard to advocate on, and I think that we have some incredible patient advocates. I see Catherine was on here as well as Pat and Emerald that are working on what we can do to raise awareness around ACC. So the PAN Foundation offers financial assistance, but what's interesting, and this can be even for Medicare patients, regardless of your insurance, you can apply here. ACC is not listed as a condition that's covered by the PAN Foundation, but interestingly, Cushing's is listed and Lysadren is listed under Cushing's. So we're really going to focus this year on getting ACC listed as a condition. But if you have Cushing's, Lysadren, you can get additional financial support from the PAN Foundation if you qualify. And then the last bucket is for those in financial need that cannot afford their medication, are underinsured, or may not have insurance. So depending on your income and sort of the coverage that you're experiencing, you can go through, you can, like I said, you can let Walgreens Alliance know that you need financial assistance. They can send you to a third party. It's Direct Success for us. And they will take information from you, see if you qualify, and then you can get your medication completely at no cost to you. Those are the 3 main financial support programs that exist right now. Again, always subject to change. But if you have any questions, we'll have the contact information. We're happy to help you and support you in any way. On the next slide is special considerations. I just, again, want to bring your attention to a couple of things. The copay card offset may not apply to your deductible. You should speak to your insurance company about that. If you are a government-funded insurance like Medicare or Medicaid, you can't use the copay card. It's against there are laws that the government, we call them the anti-kickback. And then Medicare. If any of you are on Medicare or approaching enrollment into Medicare, the Inflation Reduction Act is going to see some really positive changes, especially for those of us in the chronic and rare field. So you will see significant changes to what you will be spending as a Medicare beneficiary out of pocket. Good changes, meaning you're going to be spending less. So in 2024, you will see that you will no longer pay 5% out of pocket for your medication once you reach catastrophic coverage. It'll drop to $0. So once you get into catastrophic coverage on your Medicare D, which is your drug plan, you will pay nothing out of pocket, which is fantastic. Right now in 2023, patients are paying 5%, which can get very expensive. Then in 2025, that you will still continue to pay nothing in catastrophic coverage out of pocket, but you will go down about $1,200 in your out-of-pocket max. It'll drop down to $2,000. So you'll spend $2,000 in maximum over the course of 12 months, starting in 2025. So as promised, this last slide here is the contact information for Alliance, Direct Success, that's our patient assistance program, and then an individual contact, Val Sermali. She's actually here watching and listening to all of the wonderful presentations. Val has been supporting ACC patients and mitotane patients for going on about 8 years now. She is our field reimbursement specialist and a pharmacist, and here is her email. So if you have any individual questions. And certainly she's reaching out to physicians as well to help them in any coverage challenges. But it has been a sincere pleasure and privilege to speak to all of you. I cannot believe the incredible number of people that are here to support one another. And I just wanted to introduce myself and let you all know that we're here as well as a collective team, if we can support you in any way as you fight the fight here and support each other. And Tina and Sarah, Tina, you must be an incredible rock and pillar, but you definitely touched me. I can see the tremendous support network that is here. So thank you, everybody. And again, if there are questions, please reach out, but I'll turn it back over to Dr. Del Rivero and back to the medical experts.
Great, thank you so much. And Amanda, can you bring everyone now on stage, Dr. Katja Kiseljak-Vassiliades, and as well as Ms. Kelly Price? I think there is a couple of questions, and thank you so much, Mrs. Price, for everything that you told us today about how patients can have access to Mitoten. And yes, our ACC community is a very close community, and is always so impressed. Every day I'm impressed by each one of them. And with that, I would like to ask you a few questions. I know that we're running a little behind, but these are questions that were asked by our ACC community, and I would really like to take a few of them. And the first question that I have here is about a question about the triglycerides. One of the side effects of Mitoten is high triglycerides. And what are the options for treating this side effect from Mitoten, and how often the triglycerides needs to be checked while on Mitoten?
That's a great question, and I think that's there's not a lot of recommendations about treatment of what we call hyperlipidemia or high cholesterol. We know that all of the particles go up. So the LDL is the bad cholesterol goes up. We know that the good cholesterol, HDL, goes up, and then the triglycerides go up. So in general, there is not a very clear relationship of triglycerides to cardiovascular disease, meaning it's not very clear whether triglycerides cause heart attacks, even in patients that don't have ACC, the patients that have ACC. So the relationship is not really clear. The thing that we do know from a lot of studies that the triglycerides can cause pancreatitis. And so in patients that have high triglycerides, my threshold to treat that would be if the triglycerides fasting are close to 400 or 500. So if they're at that level, that's the level that you think about pancreatitis, then I would treat triglycerides. Otherwise, if they're like 200 to 300, that's monitoring usually. So that's my usual clinical approach to that.
Great. Thank you so much for that answer. And that will be a question for Mrs. Price. So it's about the Mitoten, the pill. One of the questions is, can that make the pill smaller or oval or candy-coated? There is a patient that takes 14 pills a day, and maybe a difference on the size of the pill maybe could make a difference. So I don't know if Mrs. Price may have an answer for that question.
That's brilliant. It's a brilliant question. So we acquired Lysodren from Bristol Myers about 5 years ago. And the answer is, I won't promise anything, but what I will say is we are looking at, is there ways to optimize formulating this for comfort for the patient for taking, and also a formulation that may decrease side effects. So we are not giving up on optimizing the vehicle and the way it's taken and all of those things, but no promises where that will lead, but I'll keep the community posted for sure.
Great, thank you so much. One other question here is about, and maybe that will be for Mrs. Price and maybe Dr. Kiseljak-Vassiliades, maybe you may want to add to that question, is about what kind of research has been done on genetic testing and correlation with efficacy of Mitoten.
Dr. Vassiliades, I'm not familiar with any, but I'm 3 months into this. So I'll leave it to you if you know of any.
Yes, so that's an excellent question, and that is I would say that's $1 million, more maybe $1 billion question. What is the correlation of Mitoten and who are the responders. In the study that I had shown from 1960s, one of the comments in the discussion of that paper was, it is very hard, they did not understand why some people respond, why some people do not respond. That question is still a remaining question 55 years now that mitotin has been approved. Who are the responders and who are not? There are some polymorphisms that researchers from Germany have been looking at to maybe decipher who is predicted to be a responder and who not. But really, that question of who is going to be a responder and who is not has not been answered. Unfortunately, we know in the lab that one of the cell lines that has certain mutations in p53 and beta-catenin has a good response in the lab, but most patients do not have both of those mutations. So who are the people that are going to respond? Unfortunately, that genetically has not been answered, but that's a huge area of research, and we would love to answer that question, because then we would be a step closer to what we call precision medicine, meaning that a person with a specific genetic mutation would be appropriate for a specific treatment. We have different treatments now. We have mitotin, chemotherapy, immunotherapy, different kinds of kinase inhibitors. And sometimes some people respond to each one of those. Who are those people? It's been not very clear, but I am very, very interested in that question. And that's one of the goals of my research, is to really decipher who are the people that are going to be responding to different treatments.
That's excellent, Dr. Kiseljak-Vassiliades. Now, I do want to address this question. I know that we're running out of time, but I do want to address two questions that I think are important. And one of them is, Dr. Kiseljak-Vassiliades, maybe you want to start, and then Ms. Price can add, based on also their experience at the level of HRA Pharma. But there has been a lot of discussion within the ACC community about the results of the Aduvio trial. Because I think that now patients feel that, based on the results and what it said, that not everyone needs to take mitotin. So the question is about if there is any solid evidence of mitotin efficacy in preventing recurrence in R0 resection, and that's referring to the Aduvio 1 results with Dr. Berudi and Dr. Fastnack, and also what if the guidelines has changed about that, and what will be the recommendations? And maybe Dr. Kiseljak-Vassiliades, maybe you can touch base about the Aduvio 2 as well, and maybe you can explain, because I think it's important for our ACC community to understand that, because there has been a lot of confusion, and some of our patients feel, well, if there is no benefit, why I need to take mitotin? But maybe you can clarify why some of our patients needs to be on mitotin, and why the results of the studies.
Great. So that's another excellent question. And so my answer to this is that the Aduvio has been presented now twice at the Endocrine Society. Multiple investigators have read the preliminary data. And the thing that you do have to understand is there is a reason the paper has not been published. The paper is not published yet because there has been a question about the power. So the question has been, do we really have enough people enrolled in this study to answer this question? So the overall result right now, as it stands, is that there is no statistical difference between people that are on mitotin and not on mitotin, and they have low-grade disease. The issue is that although there's no significant difference, there is some trend that there's maybe some benefit, but again, it's not statistically different. So we're now talking about math. And the thought is that a lot of investigators felt that we really need to have enough patients enrolled in the study, in the trial, to answer that question correctly. And this is why the Italian and the German investigators are still looking. They are still collecting data, and they really want to publish this trial when it's ready to go. So the guidelines will not be changed until there is a clear answer. And I think right now there is no clear answer. So obviously, a person now has just diagnosed with ACC and they're not sure what to do. This is really an important thing to discuss with a doctor. So you can get some of the preliminary data to look at yourself, and the doctor can explain to you. Most of people here have been seeing an expert, and that's very important. And it's really important to look at the pathology. Every single thing on that pathology is a very important thing. So you look at the pathology, you look at, you speak to a doctor, and then the decision is made. So this is not a very clear answer because every single person is different, and ACC is a very heterogeneous disease. So really, I can't give an answer even for the low-grade disease right now on this forum, because even every low-grade disease is different. And I think every single expert will look at that pathology, will talk to the person, will see their age, will see their comorbidities, and will make the decision based on that.
Great. Thank you for that answer. Anything you would like to add, Mrs. Price, to that question?
No, I think that's perfectly and beautifully said.
And we have a lot more questions. That said, please, we know about the questions and we can always answer the questions even after the webinar. But that said, I just want to ask one last question because I'm seeing it also in the chat. It's about the how long the patient needs to be in mitotained in the adjuvant setting. Some doctors may say 5 years, some others may say 3 years. So maybe Dr. Kiseljak-Vassiliades, you want to comment about that? How long patient needs to be in mitotained after surgery? And maybe Mrs. Price, she would like to add anything else.
Yes. So as I said in my talk, this is basically what I call a data-free zone. There is really not a lot of data or scientific data one way or the other. The experts, again, said very clearly, people that have R0 resection and have been recurrence-free for 5 years, that then there could be consideration to stop mitotaine. Unfortunately, there are not a lot of people who have been recurrence-free and had an R0 resection with ACC. But if there is such a person, I think then 5 years is a reasonable thing. Most of my patients, the people that are long-term survival, we have done what I call cherry picking. There is a tumor, we go to surgery, get it out. A few years down the road, there's another tumor. So that's not recurrence-free. We are on mitotaine and we're treating and keeping mitotaine ACC in check. And so that's not really that recurrence-free group. But yes, if there is a recurrence-free and a good resection and you're 5 years in mitotaine, I think the consideration to stop mitotaine at that point is a valid one.
Great. Thank you so much. I'm sorry we're run out of time. Thank you so much to our speakers today for this fantastic session. I'm certainly learning a lot as well today. And with that, I just go back to you, Amanda. Thank you. I'll see you in a little bit.
Hi, we're going to take a really quick break just to regroup. We'll catch up in just a moment.
Okay, well, welcome back from our break, and we will go now to our next session. And I think all of you have the schedule, but we are gonna just change the order a little bit. So we will actually have Dr. Jonathan Hernandez present his slides first. Just for a brief introduction, Dr. Hernandez is an associate professor of surgery and chief of surgical oncology section and the surgical oncology program at SCI at NIH in Bethesda. He has been very interested in adrenocortical carcinoma and the new ways to treat, and his research focuses on human tumor explorations to develop combination therapies for tumors like adrenocortical carcinoma. So Dr. Hernandez, I will leave you the podium.
Thank you very much. Let me share my slides here. Let's see. Sorry, let's see.
You were good. If you need any help, let me know.
Yeah, how do I do this?
Present.
Yeah.
And then it should be, you can share your screen if you would like.
Yeah. Okay, share screen. And then I don't see the screen to share.
Yep. It will pop up for me in a second. And then I will put it up for you. You don't see it?
No.
So present, share screen.
Present, share screen, and then let's see.
Thanks for your patience, everyone. Sorry, I've been technical stuff today.
Slides. Maybe maybe I could do it this way. It looks like it's uploading.
Perfect. Okay. And when it's up, I will pop it up there. Sorry about that, Dr. Hernandez.
Oh, no problem. It's my fault. I'm sure I messed this up in some way.
You're good.
Are we live?
Unfortunately, yes.
Perfect. Yeah. Okay, good.
Yep.
There's some movies in this, so it's probably going to be big.
Okay.
It may take a moment. Sorry, everybody. This is entirely my fault. Amanda should not be blamed for this.
I appreciate that, but let's see, is it popping up for me yet? Here, I'll just take us off for 1 second. We'll be right back, everyone.
Are we live, Amanda?
You are live. You are good to go.
Can I advance the slides, or do you have to do it?
Do you have, if you hover over, do you have a button?
I see. Okay. Okay, perfect. So sorry about that. And so I've been asked to talk about when is surgery indicated for metastatic ACC. So just as a background, ACC commonly metastasizes to the lung, liver, and to bone. Dr. Del Rivero provided us, I think, a very insightful study about the doubling times of these lesions. And the liver lesions tend to grow the fastest. And lymph nodes, and this was, the doubling times, this is measured radiographically of 27 days, whereas liver and lymph nodes can be quite longer. And this sort of helps us as a guide. I will say I'm not going to answer the question of the title, because when is surgery indicated for metastasectomy, for metastatic ACC? I think I feel strongly it has to be weighed on an individual basis. And there are things that help us sort of make these decisions, but and I'll go through some things. And we've certainly done some studies on this. So this is a study I published a couple years ago. And we grouped patients, whether rightfully or wrongfully, we grouped patients insofar as survival. And we looked at patients who after metastasectomy lived less than 12 months. And we looked at people, we broke the group up and said, okay, what about people who lived more than 2 years? And we said, okay, we're probably, whether right or wrong, probably helping people who lived more than 2 years, and those patients who didn't survive a year, maybe that was not the right decision to perform a metastasectomy. Again, that whether right or wrong, that has to be made on an individual basis. And what comes out is that the disease-free interval mattered. And so patients who had recurrence after a year tended to do better. So if you look at those people who lived more than 2 years after the metastasectomy, it's because they had a disease-free interval, or at least association with the disease-free interval over a year. The other thing that was important to note is that for patients who lived more than 2 years, they tended to have multiple procedures, which would sort of be in concert with this fact that once somebody has metastases, the process can be systemic. But again, these are sort of generalizations. This is a sizable patient population that we looked at. This may or may not be true for any one individual patient. And I certainly, again, gets the fact that I stated earlier that things need to be made on an individual basis. This is another study we did that was published a few years ago, looking at whether functional or non-functional tumors impacted survival. And we found that non-functional tumors, those patients tended to do better, again, broken up by less than 12 months, and those who survived more than 24 months. Again, this doesn't, there are certainly patients who don't fit into that less than 12 months, disease-free interval and the non-functioning status that I think we can help. And so I would emphasize, though I'm showing you groups of patients that we've sort of analyzed based on our experience, it has to be highly individualized. And I've taken that approach. And so the next slide I want to show you, the movies didn't load. That's, well, this is going to be far less effective without this. Amanda, is there anything we could?
Let me see. Huh.
I wonder if I could present it off my desktop. Do you think that would work?
Possibly. Yeah. I would try. We can try the present button again.
Okay.
And the share screen, hopefully. Maybe it'll work this time. Cross my fingers.
Okay.
And then let's see if it shows up. I'm going to remove this for a moment.
Mm-hmm.
Okay. Are you able to
share entire screen?
There we go.
Let's do that. Are you seeing my screen?
No, I am. There we go.
How's that look?
That looks good.
Okay, you can see that?
Yep.
Are you seeing the video?
Is it playing?
No.
Okay, but yep, we can see it.
Okay, so my approach to metastasectomy, I would say, is aggressive. I feel like if we've made the decision that surgery is indicated, then I'm going to do everything I can in my power to make sure it doesn't come back locally. When I talk to people about this, I make no promises about the systemic nature, about the recurrence, because if it recurs elsewhere outside the confines of the operation, that's a biological issue. And I think of surgery as a mechanical solution to an incredibly complex biological problem. In some ways it's stupid, but in some ways it's probably the best we have. And so my approach aggressive with the surgery so to make sure it doesn't come back in the local area. I will take videos for patients, and this just shows you the type of specimens that we remove.
Okay, Sarah, this is your kidney. You see we stayed way away from everything. There's a little tumor enveloped in the kidney area here. this is liver. So I cut the liver this way. It sat inside of you like this. So I stayed away. You can start to see some tumor here. Now we cut this open after it came out of you to look at the tumor. So this sat like that. And so here's your tumor, again, enveloped in this whole piece. This is the back, and this is a little bit of your diaphragm here. Okay, so this all came out of you like that. All right. Okay, there you go.
And this is what the patient looked like on the table when the specimen was removed.
Sarah, this is your duodenum. When we flip that over, hold that, Jacob. Hold that over. So that's your vena cava here. And your kidney came off here, so it was in this area. Now I think you can see there's nothing left in this area. I cut off the end of your liver, which is here. And this is actually in your chest. I got to remake your area here with a piece of mesh. Remake your diaphragm over here with a piece of mesh. But this is your liver chopped off, your kidney gone. Here's your vena cava here. This is where you eat the duodenum here. And this is your gallbladder here. All right, so that area sat your kidney and the tumor, which are all gone.
So that was sort of an example that I just happened to have because the patient asked me for it. And so, you can see that, there were probably some smaller tumors, but I was unwilling to do this without cutting out the whole area, because I feel for this particular patient, with localized recurrence, if the goal is to rid ourselves of localized recurrence, that can be done. And it can be done with success if you stay away from everything. And that requires multivisceral resections. And this patient, from this perspective, has done well postoperatively. I usually tell people, you can be fine with one kidney. You don't need that much of your liver, maybe 20 to 30%, depending on how much alcohol you've enjoyed throughout your life. You don't need a lot of things. You don't need, you need some of your pancreas probably, but you can live without it. You don't need your spleen. What you don't do well with is the disease comes back. And so we do everything in our power to make sure of that. And what I would say is I'm going to show you two scans that I've done. This was the first one referred to me by Dr. Del Rivero. This is a patient who had longer disease-free intervals but had multiple operations. This is a recurrence of her adrenal cortical carcinoma in her pelvis. This was in 2017, and I'm just scrolling through the scan. You can see this massive tumor here, probably more than one, very close to her iliac artery and vein there. And this was a difficult operation. This took me a while, but I'll show you her scan from, this is her most recent scan in 2022. She is alive, NED. There was certainly a price paid for that operation, but I ran into her not too long ago, and she couldn't be happier. And this is her most recent scan. This is another patient who I operated on not too long ago, 2018. You could see these multiple liver metastases. But this patient never had a disease-free interval. You look at her scan today, she has some fluid collections in her liver, but there is no more tumor. And she's gone a long way with no tumor and no disease-free interval. So by my old with the slide I showed you initially, talking about disease-free interval and helping us to select patients, if you use that sort of criteria strictly, I would not have operated on her. And she's done extremely well. She got to see a lot of her daughters, sort of growing up, and crucial time in her daughter's life, and she wanted extra time, and I was certainly agreeable to do this for her, and she's done exceptionally well. I have a feeling she's going to continue to do exceptionally well. This is another case of a patient that I wanted to present because I think this one changed my opinion about things. This is a 43-year-old lady who had symptoms of adrenal cortical hormone excess, including uncontrolled hyperglycemia, significant weight gain, poor wound healing, lower extremity venous thromboembolism. She had laparoscopic adrenal surgery where this sort of stuff was identified, found to have high cortisol levels and adrenal mass. She was started on EDP, etoposide, doxorubicin, and cisplatin with mitotane for 6 cycles, progression of disease in her liver, started on Pembro, further progression. So not an uncommon scenario where the sort of systemic lines are exhausted. I'm showing you some of the tumor. She had a lot. And if I show you the diffusion weighted images, she had a lot of disease. And although I could probably cut out most of these, I felt it would be almost impossible for me to resect all of them. So I offered her something else, and I offered her this. So I said, I will remove your primary tumor. So I flipped her pancreas and spleen up to the other side. I resected her kidney, portions of her diaphragm, and then I cut out a bunch of her liver lesions, but I couldn't cut them all out because she had innumerable disease. But I did place this hepatic artery infusion pump. This is a strategy that's mostly employed with colorectal cancer, sometimes with intrahepatic cholangiocarcinoma, but it's a way to get a lot of chemotherapy into the liver. This wouldn't be the chemotherapy we know to be most effective for adrenal cortical carcinoma, so I didn't really know if this was going to work. This would be the second case ever done. The first case was done in Kentucky by a friend of mine, and we were talking about doing this. And so he did it on a single patient a couple months ahead of us. But this strategy is done on 2 patients, to the best of my knowledge, in the world literature. This lady had a T2N0 tumor, obviously multiple liver metastases. Postoperatively, and after treatment, biochemically, her cortisol levels resolved. After 6 cycles of EDP, and I'm showing you a preoperative scan showing you lesions I could not get to. You can see them here. They're no longer present. They're ostensibly gone. And I stopped her therapy, and she's been NED 10 months after surgery. So this was an unexpectedly and very happy, excellent result. Again, 2 patients have been done. Both patients had an excellent response to this therapy. And so as a result of this, we've written a study, which I'd like to share with you. Dr. Del Rivero and I will be conducting this study at the NIH. This is called a phase 2 study evaluating the efficacy of hepatic artery infusion pump therapy for subjects with liver metastases from adrenal cortical carcinoma. The rationale here is that, metastases in the liver use the artery for their blood supply. And the drug we use in that pump, and it looks sort of like this, where you have this pump sitting under your skin. It's like a big Metaport, but it works in a fancier way. You don't just infuse, it sort of pushes the medicine in over 2 weeks. And it's fluoxuridine is the medicine. And this drug has been used because it has 95% first pass metabolism. So the patient does not experience anything systemic from this. It all stays locally in their liver. It gives you good results, and this has been, done for a long time, but again, mostly with metastatic colorectal cancer. And the concept here is, because we know from our retrospective look at what happens to people after liver metastasectomy in properly selected patients, those patients do well, suggesting if we can control the liver metastases, then we can probably help people. And so this is the study. Our primary objective is going to be overall response rates. We have some secondary objectives that should not be surprising: progression-free survival, overall survival, safety of this. I will say in both patients, this appeared to be significantly safer than we didn't see any issues with the bile ducts. I don't really understand that. N of 2 is not enough, but sometimes with the other patients with the other diseases, we see issues with the bile ducts. I think we're going to need to run the study to understand that better. And then we're going to look at HGF levels. There is a drug available that can inhibit HGF levels, and there is a paper from MD Anderson showing that HGF levels are important for this disease, and so there's a potential to add another systemic agent, but we need to know that first. The inclusion criteria is sort of patients are going to have to tolerate some systemic chemotherapy, although I'm wavering on that, and we may not include it. They must have, of course, measurable liver disease. We wouldn't do this unless someone has received at least first-line chemotherapy, so that would, of course, likely be EDP. ECOG status less than or equal to 1, and then, sort of generalized laboratory values. I think the important exclusion criteria, we want to have cortisol levels under control. The pulmonary metastases is an issue. But I think, I showed you Dr. Del Rivero's data about doubling times. And we do often feel that the liver disease may be survival limiting. And so I think there are a number of patients who have this sort of quiescent or slow progressing lung disease where they're not going to get into trouble anytime soon. And so as long as patients had a resist stable lung disease for at least 3 months, and I felt like their liver, was going to get them into trouble, I think those people would qualify. We would take them on the study. So this looks like this. Now, there are things about this study that you have to know, and this obligates you to come back to the clinical center in Bethesda every 2 weeks because we have to fill your pump. And that's every other week we fill it with FUDR and dexamethasone, and then every 2 weeks, then it goes to fill with heparinized saline. We've been talking about this with Dr. Del Rivero, if we want to include any systemic agents. I don't know yet whether we will include this. This study will go to SRC soon, so we're going to have to make up our mind. It's going to accrue 6 patients. If one of the first 6 patients has a resist response, we're going to go to 10, and that's going to be our population. If this looks like it works for patients, we will continue to do this, of course. I'll stop there in the interest of time, and I'll conclude. And I would say, I've talked about a lot and I've sort of skimmed over some things, but this is a complicated process. I would say patient selection is paramount. I would say metastasectomy is indicated for patients with ACC, but again, you got to do it in the right patients. There are multiple things that are weighed. There's going to be technical factors. Is this operation feasible? What's it going to cost the patient in terms of morbidity? These are, of course, this gets into patient wishes. The disease-free interval is not an absolute. I think if you have a disease-free interval over a year, that would certainly make us encourage us to sort of, I think it helps us decide. But I showed you data from patients who did not have a disease-free interval of a year. In fact, they had no disease-free interval. And so I think that's only one variable. We do like to consider progression of disease at other sites, including lung. And so that has to be weighed carefully if we're going to do something aggressive in the abdomen. And then, of course, if it's a local regional recurrence, I think that's different than a multi-site recurrence. So all of these things have to be weighed, and you can't do it I can't generate a flow diagram saying this should, if this, then that, if this, then that. This is complicated, and it has to include an open discussion with the patient. I will also say that a hepatic artery infusion pump in combination with resection or ablation may be an effective strategy to control liver metastases. I'm very excited about this. We've certainly seen bad outcomes from recurrent liver disease, and if we have a better way to control it, I think that's going to be incredibly important for patients. I'll stop there, and I guess we'll take questions at the end.
Great talk, Dr. Hernandez. Okay, so we will move to our next speaker. Again, we are a little bit out of order, but we will get to all of our speakers. So next speaker is Dr. Hoang, and he's a principal investigator at the thoracic surgery section at NIH, the National Cancer Institute. Dr. Hoang has been interested in endocrine or neuroendocrine tumors, and his research interests are in developing novel biomarkers and therapeutic strategies in thoracic cancer. So, Dr. Hoang, I will leave the podium to you.
Great. Just an audio check. Can everybody hear me and see me? And am I correctly sharing my screen?
You are good. Let me add you. There we go.
Here we go. Okay. And then can you guys see my pointer?
Yep, you're all set.
Okay. So thank you very much for having me here, and I appreciate the opportunity to share some of our kind of local practices here at NIH regarding lung metastasectomy for metastatic ACC. And certainly I thank Dr. Del Rivero because the bulk of all of these clinical cases come from her referral. And on the heels of Dr. Hernandez, I took some notes, and we kind of in general approach this somewhat the same, just different organ. Now I'm trying to, let's see here. My slides are not advancing for some reason. Why is that? Mm-hmm. Try. Here we go. Okay. And so just a primer for everybody. Why is the lung included in this talk? It happens to be the most common site of metastasis. And the way you can think of the lung is it's basically God's best fancy filter of the blood. And the metastatic tumors are these particles. They start out as particles. And so this graphic cartoon illustrates that the lungs naturally are a homing site to capture these metastatic tumor deposits that then take root and then unfortunately grow into multiple metastatic lesions throughout the various lobes of the lungs. Up to about, the majority of ACC patients will develop lung mets. And so from the literature, and it's kind of all over the place. So this is kind of a summary of what's out there, is about 40 to 80% of anybody that walks through the door with ACC will eventually develop lung metastatic involvement. And this number I pulled from the current literature. The median survival after undergoing lung surgery in a multitude of single institution retrospective studies is somewhere between 14 to 30 months. And we're currently here at the NIH looking a little bit more closely and objectively at what this true number actually is. And I'll share a slide towards the end of the talk about that. All right, so just a primer. I'm going to show my talk is comprised of multiple CT scan images. So I just wanted to get everybody oriented because that'll be the bulk of what we'll be viewing together. And so here in the upper panel, just to note, every time we're showing you a CT scan on the screen, the left and right side of the body is reversed. And it's because of where you're looking. So we're actually, on all the scans, it's situated that we're looking from the feet up to the head. And so the left and right side are reversed anatomically. The bony spine is your back. And here in the coronal view, that's how it looks. So hopefully that makes sense to everybody. So, and then I just divided the talk very simply and practically into general clinical indications that we consider every time we're asked to view a case for lung surgery. And so the first half will be things that we think merit lung surgery. And then the second half of the talk will be contraindications in situations where we don't think lung surgery is either technically meaningful or it probably just isn't ready yet in terms of timing. So here, these are common scenarios that would trigger a recommendation from us in thoracic surgery to recommend lung resection. So here you have a picture, follow the yellow arrow. This is the heart, the central structure here. And so we're looking at the right lung, and this tumor happens to be growing and attaching to the pericardium or the lining of the heart. So tumors that are getting close to critical structures, obviously you can't live without your heart. Tumor involving vasculature. So here's a picture of a similar tumor in different region of the lung where there is a artery and or vein in the lung that is also being involved in the tumor. And a lot of times what happens is the tumors actually pull in and kind of generate abnormal arterial blood vessels to kind of feed itself. And so it becomes a big problem in terms of letting that such tumors persist. So if you see stuff like this is kind of generally what we would consider time for surgery. Here's another tumor that is also, again, in proximity to critical blood vessels in the lung, and it's sitting very central. So tumors that grow central tend to push forward the timing for surgery as opposed to tumors that are peripheral, okay? And I'll show an example of a peripheral tumor, but And the reason why is because when the tumors are growing in between things, they're basically set up to very much disrupt normal anatomy, obstruct airways, and cause a lot of clinical problems. So here, in addition to being central, the tumor is also large. So once it starts to increase in size and occupy a lot of what would otherwise be normal lung functional tissue, that also is an impetus for us to recommend surgery. And here, and you can think of it as a tumor that's occurring upstream. So those are the more serious ones, and the upstream or the central tumors often grow around airways. They involve the central arterial and venous blood supply to the lung. And in this particular instance, and we're looking at the right lower lobe here, is that not only do we have a large growing tumor involving the central airways, here you can see some airway compression. You also, this one, the other advantage of doing an entire lobectomy is throughout the right lower lobe, there were multiple other tumor deposits. So doing this one anatomic resection got rid of a large volume of tumor, which was advantageous for this patient. So this is another example. So large lung tumor size. Okay, so those are some of the basic kind of considerations we see, and then go ahead and recommend moving forward to lung resection. Now here I'm going to show you some examples of tumors that might not be advantageous to the patient to undergo surgery. So exceedingly small tumors, in general, we use a practical size cutoff of about 10 millimeter diameter. And here this one is 2.7 millimeter in diameter. It's this tiny little dot that you see in the screen. Again, this is the right lower lobe. These tumors, one, if they're very small, two, this one happens to be in a peripheral location. And when I say peripheral, the way you can think about it is on these CT scans, if you kind of draw an imaginary line and you kind of cut the lung in half, and then you cut the lung in half again in the opposite direction, this would be central. So anything on the outskirts of these imaginary lines, this would be peripheral, meaning that it is on the surface of the lung, it's closer to the rib cage. So this is the chest wall with the muscles, and these are the ribs here in bright white that you can see on the scan. So tumors that are exceedingly small are difficult to palpate, one. They're difficult to visualize if they're any more deeper than just surface deep. And as they go more central, they're essentially impossible to locate. And so you can't cut out what you can't locate. That's kind of the general rule. And so for tumors like this, then what we often do is pursue a surveillance strategy where we will then continue to watch these tumors once they grow at least to about a 10 millimeter size, and or there's other clinical factors that would trigger surgery for such patients. So that's one example. Okay, so here again, just small, but things that are on the surface. So metastatic tumor deposits that are very much on the surface of the lung. So here we're looking at a tumor in the left lower lobe. It's right here, quite small. But things that sit out on the periphery, you can think of as like, disease branches of an oak tree. So the leaves, if they become problematic, you might not necessarily have to do anything, as opposed to disease on the trunk of the oak tree, which is what I was trying to convey with some of the earlier pictures of centrally located large tumors that are involving critical structures in the anatomy of the lung. So here we, again, usually use a wait and see. If these tumors become faster growing, if they start to become pleural base and attach to the chest wall, or there's other factors that would, trigger surgery, then we would take all of these out at that time. Tumors that are not dense. So all metastatic tumors start out as essentially single cells. which you can consider like a seed. And so oftentimes you can't visualize those until they attain a certain type of mass and density to be completely visible and localizable on CT scans. So here we're looking again at the left lower lobe. I circle the 2 yellow circles indicate subsolid lesions that are not truly dense. These other spots that you're seeing here, this is IV contrast. So this is an artificial enhancement of the vasculature in the lung. And so tumors that are not dense, obviously then we have a very difficult time palpating them. We can't really see them. And then if they're not sitting on the surface, then and they're deep, like these 2 centrally located subsolid lesions, then it's almost impossible to localize them to be able to cut them out. So tumor density is another factor that we weigh. Here's a sad example of somebody that we didn't end up offering surgery for. So there are multiple large tumors, but here are some of the issues were invasion and penetration across the pericardium or the lining of the heart. And in fact, this one on echocardiogram showed that the tumor had actually invaded into the muscle of the heart. So this was quite an advanced case. Over here you see, and it was bilateral. So here we're looking at a very large tumor abutting the right atrium of the heart. The heart has 4 chambers. And here that's penetrated through, so we're on the right. And then here on the left side, you can see in this other view, there's multiple areas where the heart and the pericardium are involved by metastatic tumor invasion. Here, this is also a large central left-sided tumor. It involves the left lower lobe. And I think there was actually evidence with this one actually crossing from the left side to the right side through the posterior mediastinum. And then this structure that's outlined with the red circle here is the aorta. That's the main arterial blood vessel that carries blood away from the heart that feeds the rest of the body. And so this was a very, very advanced case that was, we would define or declare this technically not resectable, at least for most of us, maybe not Dr. Hernandez. Yeah, so this, you know, and these are more rare. So I haven't gotten a lot of these types of referrals, fortunately, because, you know, folks with ACC and metastatic disease get plugged in much sooner. But this, I don't remember the specific circumstances of how we came across this very advanced case. Okay, so that's it. My talk is pretty short and sweet, and I just want to summarize again kind of the things we went through. So the things that we do indicate is if the lung is the only organ, definitely we very much want to operate on that. It's although rare, we sometimes see single site, you know, single tumor lesions that are, you know, that just kind of sit there, nothing new pops up over a prolonged period. Those are ideal cases to operate on. And that is sort of the same thing is that, and I think Dr. Hernandez mentioned that several times, and there are different ways to say it, but disease-free interval, progression-free interval, and otherwise stable metastatic disease where there's a period of time, whether that be months, weeks, you know, sometimes, you know, a year or more, where you don't see a lot of new tumors or tumor growth in the lungs, then that's definitely a very favorable situation. Again, I talked about some size criteria. We don't want to, it's hard technically to go after very small things. So we're looking in general empirically for things larger than 1 centimeter. Things that are central need to be looked at closely up front because as you can see, they grow large. Once they've happened centrally, there's nothing we can do to change that central location. And then as they grow larger, they become much more problematic. And we often don't want to wait until there are actually symptoms like, you know, people are having persistent cough, they're coughing up blood, they're getting lung infections because of airway obstruction. We want to avoid those situations. And then there are some, and I didn't go, it was hard to give a static image of what we call oligoprogression. So in folks with multiple tumors, there's a state where some tumors rapidly grow and then the rest of the tumors don't really do much. We definitely want to go after the ones that are moving faster than the others. And we call that a state of metastatic oligoprogression. And I can talk some more if there's other questions later. And then in general, some indications that would argue against surgery is that we want to avoid the folks that, I call it the tip of the iceberg phenomenon, where they show up and there's tumors and they all look resectable and we say, okay, let's resect them. But what we can't figure out, and we don't have a good biomarker for it this time with this disease or pretty much most of cancer, is how quickly new tumors are going to develop, or those things that are subsolid that haven't evolved into a visible state on the CT scans. Then every once in a while, when these patients, it's hard to detect these patients up front, and every once in a while when we operate, and then a month later they come back for the post-op check and there's more tumors, and they said, oh, you missed them. This could be that situation where there's rapid development, and that's kind of what we want to avoid, because then we, every time we do more surgery, it's harder to go back. I showed you an example of what we would consider systemic or diffuse organ involvement. And then we talked about just waiting on the very, very early subsolid lesions, or the very small and peripheral ones that are not going to harm you anytime soon. So that's kind of it. And then I just wanted to finish with, because this is a surgical presentation. Oh, this is not going to work. But there's kind of two ways. So we always want to preserve lung with metastasectomy. So this is just in multiple different formats, both in cartoon, drawing images, and a video, just to show you that we try and save the good lung. We try and cut out all the tumors in their entirety. And then this is the open way, where we would make a thoracotomy incision and have to spread the ribs, and the surgeon gets his hands in and really do things. This type of open approach is best suited for tumors that are centrally and very deeply located, where we can basically carve a hole or a tunnel from one end of the lobe all the way through the other end, and then close it up, as you're seeing here in the bottom video, with some suture, and thus preserving the remainder of the functional lung. And this is a particularly effective technique for very central located tumors. For those that are much more peripheral, we prefer a surgical approach that entails small incisions via minimal access. And let's see, oh, they're working sort of. I split these videos up. So we have kind of two general techniques. One is the VATS, video assisted thoracoscopic surgery, and RATS is robotic assisted surgery. These involve multiple small incisions between the rib cage, and we can go in and use this minimal invasive technique to go after tumors that are on the surface. So here's an example of a small tumor sitting on the lung surface. We can get in there, we can easily localize such tumors that are sufficient size, and then basically use cutting stapling devices that essentially cut out a little tiny wedge slice, cake slice, if you will. And that's what these videos in real time are trying to illustrate. And then we just put that wedge into a bag and remove it out through small holes. And this kind of small incision surgery allows for repeat surgeries much more easily. And the pain is less, so the recovery time is faster. So there are a number of preferred advantages to such a technique. But as you can see, depending on your specific situation, we offer one or the other in terms of what the end goal is for each particular patient, and it's going to be a little different. All right, and that's it. And then I mentioned a little bit, and this is unpublished data, so I'll just talk about it, and hopefully I'll be able to publish this and then come back and show you actual data slides. But several years ago, it's probably been over 10 years, I think, the NCI put out a lung-specific metastasectomy in ACC patients, but I think that cohort was pretty small. It was like 20 patients at the time. And then since then, we've done a larger, more comprehensive retrospective review of our entire database. And I think we're working with somewhere between like over 70 patients in this current cohort that we hope to publish in the near future. These are patients that develop only lung metastatic disease, or they present with adrenal disease and lung mets concurrently. Kind of the take-home message from our in-house analysis is that there is a detectable overall survival that measures in years. So our 5 and 10 year survival rates for this cohort of patients is a respectable about 1/3 of the group. And if you can get out numbers this long, that is subtle implication that in properly selected patients, there's probably those patients that have a favorable biology, even though it's metastatic to the lung, that if you do lung surgery, you're going to get somewhere, you're going to get a group of patients that exhibit these relatively prolonged survival rates. In our hands, the total number of tumor nodules removed is not any sort of predictive factor for whether or not the patients do well or not do well in terms of survival. The median number of lung metastases we removed in our surgical series was about 8 per patient. I've personally removed many more than 8 and quite a bit less than 8, and it just depends on the situation of the patient. The other thing, and I didn't put that up here, but one of the other intriguing findings that support this notion of waiting was that when we divide up our cohort into folks that got surgery after 11 months versus before 11 months of the time that they get diagnosed with a metastatic implant in the lung, there seems to be a large statistically significant divergence in survival, where those that we waited a little bit longer past the 11-month period and nothing else happened, that's a surrogate measure of good biology, and those patients did very well and survived much better than folks where we operated much sooner, seemed to suggest that they had a much more aggressive kind of disease state, and the cat was already out of the bag, and no matter what we did surgically, it didn't seem to improve survival. So these are some of the intriguing new findings that we have with our current large database of patients with this particular problem, and I hope to be able to present this in the near future as published data. So in summary, and I hope I haven't gone super over time, but again, the lungs are the most common metastatic organ to be involved in metastatic ACC. Lung resection in specific scenarios and selected patients may be beneficial in terms of overall outcome and survival. I talked about several different surgical approaches and the general strategies that we think about in terms of what type of disease presentation is good for surgery and what type is not. But as everybody, I think, is going to continue to echo in this forum, is that there's still a lot of questions that need to be researched and addressed. So with that, I thank you very much. This is our thoracic surgery service. I'm sure there's a lot of folks here, I think, in the forum that I've treated or recognized or consulted with, and we hope to meet more. Thank you very much.
Great talk, Dr. Hoang, and we will move to our next speaker, and then we will bring all of our surgeons and our radiation oncologists back for the questions. So I am very happy to introduce our next speaker, Dr. Krishnasamy. Dr. Krishnasamy is an associate professor, and he's a co-director of interventional oncology and interventional radiology research. He's at the New-York-Presbyterian Columbia University Medical Center, and he will present his talk next. And he's going to talk about the liver-directed therapies in ACC. Dr. Krishnasamy, nice to have you here, and I leave the podium to you.
Wonderful. Thank you. Thank you for having me. Hopefully everybody can hear me.
You are all set. We can
Perfect.
hear you, and your slides are up, so you're good to go.
All right. Okay, let's get started. Again, thanks everyone for having me. It's a real honor and a pleasure to be here and see a lot of my former colleagues and friends as well. So it's a great opportunity, and I appreciate that opportunity. So, excuse me. Like I said, we're going to talk about liver-directed therapy for adrenal cortical carcinoma and metastatic disease, and we'll get into a few different topics today. So as with everything, I like to start with a quick outline. So we'll go through some of the guidelines. We'll talk about the different therapies. There has been some recent literature over the last couple of years that's come out that's important and applicable in this space. So we'll talk about that as well. And then we'll get into patient and therapeutic selection. So looking at the guidelines, the NCCN guidelines specifically, when we're looking at local, regional, unresectable, and metastatic disease, there is a specific mention for local therapy, SBRT, or thermal ablation, or liver-directed therapy, and we'll get into those in a little bit as well. But if you go through the guidelines, they actually further expand upon this, and granted, it's a little interesting because the guidelines combine therapy for neuroendocrine tumors as well as adrenal tumors. But they do talk about transarterial therapies and ablative therapies specifically, and then the important contraindications, liver dysfunction, liver tumor burden, prior surgery, and they make distinctions into what type of therapy is most appropriate where, which I'll get into a little bit later as well. And then the same thing with ablation also, specifically numbers of lesions and size of lesions. And we use this as a general guideline, but we do move beyond this at times as well. So we'll start with a quick discussion of the therapies that are available. And within that, we'll start with percutaneous therapies, meaning through the skin, which are predominantly needle-based. And so I'm an interventional radiologist. Everything I do is image-guided and minimally invasive. And so for percutaneous therapies, I'm primarily using ultrasound and CT. But then I'm also using navigational and targeting software. And that's really been the evolution over the last several years, is the development of this software and the development of trials relying on this software to look at the ablation zone margin around the tumor. And you can imagine in three-dimensional space, with an irregularly shaped lesion in the liver or somewhere else like the lung, it's hard to really understand what that ablation zone is going to be without having some of the software. And we know that the software is beneficial. So these types of therapies are primarily outpatient. It's rare that I do an ablation where I need to keep a patient overnight. And if I do, it's usually an overnight observation. So primarily outpatient, usually with general anesthesia, sometimes with sedation, depending on the location of the lesion or tumor and the type of therapy. And then we have multiple modalities available, right? So there's radiofrequency, which is kind of the tried and true older technology. There's microwave ablation. There's cryoablation, and now we're also in an era where we have some other ablative technologies that are coming down the pipeline that may or may not be as validated yet, or maybe may or may not be FDA approved yet, but the space is quickly evolving over time. So we'll start with radiofrequency, and really this is the tried and true, the older methodology. It's the one that has the historical precedent, has tons of evidence, but it is the older therapy, and it relies on radiofrequency waves and creates an electrical current. And you can see you have to put grounding pads on, you have to complete that circuit for safety and utility. It is cheaper, it is more widely available. So generally in the community, a lot of centers will have radiofrequency availability, but not some of the other ablation modalities. That can be used everywhere: lung, liver, kidney, bone. It is controllable, but it is a little slower. And this is why we primarily use it in the bone, especially in the spine, because of that control, that slow increase in ablation zone creation and safety profile. But there are disadvantages. Heat sink is a big one. If you're ablating a lesion next to a big blood vessel, that blood flow will actually take away some of that heat and limit the growth of the ablation zone. You can cause tissue charring and limit your energy deposition. You can get skin burns from the grounding pads, and then anybody with a pacemaker or defibrillator, you can't use this type of therapy. So really the transition has been to microwave ablation, and it's oscillating polar molecules that create kinetic energy and heat. And it creates a much faster ablation zone, a much larger ablation zone. You have less of that susceptibility that radiofrequency has, and it's a lot easier to use. The problem is they just have less control. So in a safe location where I'm not worried about surrounding structures, this is the ideal modality because I can do what I need to do at a much faster pace. And then you have cryoablation, which is, as you would expect, related to ice. You know, it's expansion of argon related to the Joule-Thomson effect. It's very easy to monitor because I can see it on CT. I can see that ice ball on CT, and it's less painful. So it's often utilized for nerve ablation as well in patients that have pain related to tumor invasions adjacent to nerves. It is a longer treatment cycle, and it does utilize large tanks of gas. So from a utility standpoint, it's a little bit more cumbersome and complicated, but definitely has a role in what we do. So let's move on to some of the transarterial therapies. Again, image guided. So instead of CT and ultrasound, I'm using primarily fluoroscopy and X-ray. Again, navigational and targeting software. And we know from the literature that this is very important. Compared to my naked eye, if I have the appropriate targeting software, and these are some images we use, we segment out the tumor. We have a catheter at the entrance of the liver, the blood vessels, and the software will tell me where the catheter needs to go to treat the entirety of the tumor. And the literature has shown better outcomes as a result of that, right? So this is another example where the space is slowly evolving over time. Again, an outpatient procedure is a catheter-based procedure, just like cardiac catheterization, but instead of going to the heart, I'm taking a right turn and going to the liver, either going through the femoral artery in the groin or the radial artery in the wrist, and only generally with moderate sedation. So again, outpatient, really limited need for overnight observation. There are some cases where we do admit patients overnight for just symptom control post-embolization, but that is the rarity these days. And again, you have multiple modalities. You have radiation particles, you have chemotherapeutic particles, and then you have bland embolization, which is without anything, essentially. So getting into the weeds a little bit, looking at chemoembolization, you have two types. You have the type that mixes with lipidol, which is oily contrast, and the type that mixes with particles, which are small 40 to 300 micrometer particles, depending on what size is chosen for that particular clinical scenario. Now they're different. Mixing with oily contrast or lipidol allows for better penetration into the tumor, but at the cost of higher systemic concentration of chemotherapy. And the converse is true. Drug elution, you have lower systemic exposure to chemotherapy, specifically doxorubicin, but the particles don't get quite as far into the tumor. So utilized slightly differently for those reasons as well. Now, we commonly mix with doxorubicin primarily because that is the historical precedent, and we haven't really gotten past that. It is applicable in this situation, of course, but that is the typical drug that we use. Radioembolization, now we're talking about small particles in the 20 to 60 micrometer range, actually loaded with yttrium-90 or radioactive material. There are different competitors in the space, but it's a different beast. It's less symbolic, less symptoms, utilized differently, and we'll get to that here in a second. There are two methodologies of treatment. There's a segmental disease eradication methodology, and then the lobar disease control methodology. Now, this is two procedures. There is a mapping procedure done via catheterization, and then a treatment procedure as well. And this is for safety. The mapping procedure is done to ensure that we have the appropriate location of therapy. There's no shunts that we're unaware of that are going to cause non-target radioactive material, and then we come back and deliver the therapy. So as we were just alluding to, on the left side, A and C, when we're talking about whole liver or bilobar infusion or lobar infusion in C, this is the more traditional approach, and radioembolization has really evolved over the last 10 years or so, especially in the last couple of years, to become when possible, a segmental infusion as you see in B, and then a direct tumor infusion as you see in D. And that allows this therapy to really be a transarterial ablation, and that's what it is now being considered in the appropriate clinical scenario. And then evolving beyond that, our dosing strategies have changed as well. So historically, in our standard models, we would dose the lobar or the entire lobe of the liver or the whole liver. And you can see there's a lot of background normal liver that gets a radiation dose. And so this is where it gets a little cumbersome and complicated, because if I can't get the adequate dose to the tumor without a very high dose to the background normal liver, then we're talking about disease control, because I can't sacrifice the background liver. Whereas if I'm doing a segmental infusion or using the partition model, where I'm actually calculating the background liver dose and the specific dose to the tumor, I can up that dose to the tumor, try to minimize that background liver dose, and we're getting into more of those disease eradication strategies. All right, so let's talk a little bit about the literature, and this is a little bit complicated because obviously there's not a lot of literature and there's not a lot of prospective literature, but there have been some manuscripts that have come out in the last couple of years that are very applicable here. This was actually our NIH data that came out in 2021, which was a retrospective review of 39 patients, and this was only focused on IR therapies after surgery. As you can see, 39 patients, multiple sessions of therapy per patient, a very aggressive approach, primarily liver, but also lung and bone. And then, but most importantly, a large increase, a statistically significant increase in overall survival compared to the National Cancer Database, 60% versus 35%, and that's pretty remarkable for us. Another manuscript. This was by Ru et al. Cancers in 2022, retrospective review of 60 patients, all stage 4A disease, all mitotane plus local therapy. Again, liver, lung, bone, and other sites, but importantly included all the specialties, surgery, radiation, and IR. Multiple patients had a combination of therapy. Multiple patients, or many patients were treated by IR, 50 patients specifically. And then the proportion of patients that had disease control, 2/3 of patients, had a 71% 5-year overall survival. And that correlated well with the disease burden as well. So less than 5 metastatic foci, maximum diameter of 3 centimeters. In the other cohort of patients, the progressive disease cohort, it was a 32% 5-year overall survival. But then the other interesting thing that was found was that within that disease control cohort, 48% were able to achieve a complete response after local therapy. And they subdivided the patients based on the actual lesions, right? So surgery was primarily used for larger lesions. IR was used for the minimally invasive approach and the ability to be repeated over time. And then radiation therapy was used more for infiltrative lesions. And you can see in these images on the right side, they were aggressive. So the top row is actually a lesion in the left liver. They used a transarterial approach with chemoembolization plus an ablation. The second row was a right liver ablation. And then the third row was a bone ablation, actually. So then the final paper I want to talk about is Boliv's paper, 79 patients, and they actually compared cohorts of mitotane only versus mitotane plus local regional therapy. Again, primarily lung and liver. They limited it to 2 or less organ metastatic sites, combined all therapies, all subspecialties with a 13% complete response. Overall survival between the two groups increased from 22 months to 68 months. Median overall survival. Time to chemotherapy was also statistically different, 6 months versus 11 months. And then the interesting thing that I found was time to reach target mitotane concentration, which was 0.5 months to 10.8 months. And the authors really didn't conjecture on what exactly this meant, and I'm curious to see what my medical oncology colleagues have to say about this, but I found that very interesting as well. So let's move on to patient selection. And I think first and foremost, this is a multidisciplinary approach, right? Having a radiation oncologist, medical oncologist, surgical oncologist, and interventional oncologist all sitting out at the same table to pick the right treatment paradigm or algorithm for the patient is first and foremost. Obviously, I can't articulate and explain what Dr. Hernandez does or what Dr. Hoang does or what our radiation oncologists do. I can articulate what I do and I can plug that into the algorithm. And so the ability to have everybody at the table pick the right treatment plan for the patient is first and foremost. We've already talked about oncologic stage. That's important as well. Performance status, Dr. Hernandez touched on that. Looking at the ECOG status, we know worse performance status correlates with worse outcomes. Dr. Hernandez is going to give me a little bit of a side eye here, but we still use the ALBI score and the Child-Pugh score to evaluate the underlying liver function to determine appropriateness of local regional therapy and IR for liver or for patients with liver disease. And then obviously the medical and surgical history, right? Patients who have a lot of comorbidities, patients who have had surgery and biliary tract infection. We sway more towards one therapy or another, depending on the risk of infection or poor outcome. So how do you choose a therapy? And I think this is a tough one because there are multiple factors that are included. Obviously, lesion size, we talked about 3 centimeters, number of lesions for ablation. For those of us that do a lot of ablation, we may go beyond that with very good results, but that is the standard paradigm. Lesion location is important. Something that's deep in kind of the meat of the liver may be worse for transarterial therapy because you're going to sacrifice more normal liver, but better for an ablative therapy because I can create a focal burn or freeze in that location. There's also modality availability. Not every center has the same tools available from an ablation standpoint or an embolization standpoint. There's operator experience, and that doesn't necessarily mean that younger is bad. It just everywhere is a little bit different, and we do a lot of microwave ablation and cryoablation at Columbia. We don't do a lot of radiofrequency ablation outside of the spine anymore, just because it's the older technology. Definitely worked at centers that don't have access to Y90, and so you have some of those institutional biases and institutional differences around the country that need to be taken into account as well. But I think in the big picture, it's not about having the right therapy for every situation, because it's not a plug and play type of mentality. It's what is the right therapy for that patient, for the specific patient in the clinical scenario. And if I don't have access to that therapy, then maybe that means I need to refer that patient somewhere else to get that therapy. So in conclusion, there is a precedent for this type of aggressive therapeutic algorithm, right? You have multiple studies that have shown both aggressive local regional therapy and aggressive local regional therapy with chemotherapy show better overall survival. So this makes a lot of sense. Disease control is achievable through combination and repeated local regional therapy. And again, this doesn't just mean IR. This means surgery plus radiation plus IR. There is a suggestion of potentially better systemic response rates with tumor reduction and debulking. Maybe mitotane plus local regional therapy should be considered first line. I know that's probably up for debate a little bit, but we're talking about trying to reset the clock, and I think that's the important point. And then the final thing is, we don't know which local therapy is best, at least in the IR realm. So there's always the argument that maybe microwave is better in this situation, maybe Y90 is better in this situation, but we don't really know. We don't have that comparative data. So it's making sure that the practitioner or the IR that you're working with has the appropriate tools and knows how to use them. And then I'll stop there, and I'll be that guy that shows my cat. So who's a wonderful feline companion.
Great talk, Dr. Krishnasamy. That was really good, and I think we are going to bring all of our the 3 speakers back online. Great, and we'll have several minutes for questions. So I will start with some questions first for Dr. Hernandez. So there was a question: if the ACC is metastatic, how do you know when the patient can benefit from surgery, and how do you make that decision?
Yeah, that's an excellent question. We get asked this all the time. So before I start with that, I want to say, Dr. Krishnasamy, it's good to see you again. We certainly miss you at the NIH. Dr. Hoang and I see each other all the time, but it's good to see you.
Likewise. Good to see you guys too.
So, the question about selection and how do you know if a person will benefit, it's one of these very hard things to sort of know in oncology. And I would say if you had to pick a single way to do this, the best barometer of disease sort of biology is time. And so when you have imaging over time and you're able to look at somebody, you have that benefit of understanding what may be growing, what may not be growing, and then you can make, I think, appropriate decisions. Sometimes we don't have that, and sometimes all I can do is outline risks and potential benefits, and then the patient and I have to make a decision. It's not an easy answer, because understanding cancer biology is particularly at levels below radiographic imaging, so stuff you can't see, it's really hard. And so if all we had to do was cut out what's on the X-ray, that would be great. But we're worried about things we can't see on scans. For example, if somebody, I think Dr. Wong talked about this, if somebody comes up with a liver lesion, could we go in and cut that out, or could Dr. Krishnasamy ablate this? Yes, but the next scan could show multiple other lesions. And so getting a gestalt of the biology and time is going to give us that information, I think is ultra important. It's why you haven't heard any of us sort of really outline a clear algorithm of how we're selecting people to do this stuff for, because it can't be laid out in that way. There's too many variables, and the decisions have to be made on an individual basis. I've said a lot of words without answering the question, because it's an impossible question to answer. But we make the best decisions we can based on the information in concert with the patient's wishes.
Great. Okay, well, next question is for Dr. Hoang, and it's going to be a mixture of several different questions. I'm trying to answer as many questions as we can. So the question is, how many surgeries with the lung can really a person have? And when you see a patient that has lung metastatic disease, how do you decide whether it's time to do chemotherapy, do radiation treatment, maybe a smaller lung, or do a resection?
Okay, that was like 6 questions in one. Let me try and dissect that a little bit, and I'll echo some of the things I think Dr. Hernandez touched upon, because there is a common theme. So how many times can you operate on the lung? Well, I guess in theory you can do redo. I've done that. But past 3 or 4, it gets very difficult, because as I mentioned, with every surgery, there's scar formation and adhesions, and it makes reoperation more difficult, because organs and structures start to kind of lose their distinctive boundaries, and it makes it hard to get in and operate. And I personally, I don't know about you, Jonathan, but I haven't gone past like maybe 3 to 4 as a kind of a top limit. And then usually what happens, because we're spacing things out as much as we can, a certain amount of time has evolved to either fully declare that patient eligible for more surgery or completely not eligible and should be undergoing, other interventions. In terms of kind of the specific criteria of like when to operate, and then how does that situate in terms of a global context of chemotherapy, I think that was one of the other broad questions. A lot of that, I think, and I'll bounce this off Dr. Del Rivero, who's not on this, but when patients get referred to us, most of them are heavily pretreated, right? And so a lot of folks that I encounter are currently on some sort of drug therapy, have been on drug therapy, and then for whatever reason, either continue not to either respond or continue to progress through it to the point where they get referred to surgery. So it's sort of a kind of a self-fulfilled kind of referral pattern for us. So I hope that sort of answers the question. And then
Yeah, I think that's
Yeah.
pretty good.
Yeah, okay.
Dr. Krishnasamy, so there is a question of, can you explain the difference of ablation versus embolization, and how is that different from the traditional surgery?
Yeah, that's a great point. So, and I'll defer to Dr. Hernandez and Dr. Hoang about the surgical approaches, but, ablation is our needle-based approach. We're going percutaneously through the skin and parking a needle directly within the lesion of question or the tumor of question, and either heating or freezing it to kill it. Whereas embolization is more of the transcatheter approach. So I'm going through the groin, through the wrist, into the blood vessels to then get into the liver in this specific case, and find the blood vessels that are supplying the tumor and embolize them with small particles, either radiation particles or chemotherapy particles or bland particles.
Great. Just a few quick questions, and we'll just try to get to them quickly. So what is the hyperthermic intraperitoneal chemotherapy and when it's indicated, Dr. Hernandez?
So hyperthermic intraperitoneal chemotherapy is a technique where it's always coupled with resection or cytoreductive surgery. So this is for patients who have multiple peritoneal implants, and this, for adrenal cortical carcinoma, this usually happens when an operation, a first operation is undertaken, and you have either tumor spillage or something, or the tumor can rupture beforehand, or something like this event would happen, and the peritoneum can get multiple areas of metastases on them. And this can be a predominant sort of mechanism of metastases or type of spread for these cancers. And in this scenario, we sometimes try and apply what's used in other cancers. And ovarian would be the cancer that has this technique has shown to have be most advantageous in terms of survival advantage. And so the technique involves basically stripping all the peritoneal surfaces or the areas of concern, anything we can see, and then applying heated chemotherapy into the patient's abdomen in an attempt to clean up, if you will, any residual cells that exist. This tech, do I think this has a role in patients who have peritoneal disease? I think potentially. I don't know for sure. It definitely increases the morbidity. In some of the other studies where this has been done outside of ovarian cancer, it's been difficult to show efficacy beyond what cytoreductive surgery would otherwise get you. In other words, cutting out all the areas probably does most of the work, and adding the hot chemotherapy on top of that, it's difficult to show benefit, but this is sort of done and it's been tried. I'm not sure. I'm not sure I believe this adds a whole lot, but it's hard to say that globally for anybody who has this. There certainly have been cases where patients have done well. Whether it's because of the heat and the chemotherapy is unclear to me. I do think if you look at the data in general, the cytoreductive part of this does the heavy lifting. I do want to get back to something Dr. Hoang said about the number of cases required. How many times can you reoperate on somebody? I don't know that there's an upper limit. Certainly it gets harder every time. Liver has the benefit as opposed to lung, where the parts you leave behind get bigger and compensate. That doesn't happen with the lung. I would say that, interventional radiology and surgery are sort of have to be hand in hand. A lot of what we do, I almost couldn't do it without the interventional colleagues. And we can cut out all the big stuff and we can get to some of the stuff, but often there'll be other stuff, and interventional radiology plays a role there. And sort of we go back and forth about this sort of stuff all the time. And these two components of care need to be, they're inextricably linked in my mind. And so whether that be embolization or radiation through Y90, although I would say Y90, I do worry a little bit about the damage to surrounding liver. And so, but all of these things really have to work in concert for the patient to get an optimal outcome.
Great. Well, we're coming up to time, but I just want to address one more question that I think is very important. And I think it's important just for everyone in this community. And that's the question of research and banking. So the question here is, the question came up is there an option for banking the tissue for research? And I just want to mention that in Colorado, we have a institutional board review, and every patient that undergoes surgery is banked. And I just wanted to, just because we have our surgeons here, I want to just quickly address as far as the NIH and the Presbyterian banking tissue.
As far as I understand, Jonathan, back me up if I'm wrong, but every ACC tumor that comes out from our service goes to research via protocol with Dr. Del Rivero and company.
Yeah, so a lot of things happen when a patient has an operation at the NIH, and that gets shared with a number of investigators, and the tissue always is banked, but it's more than just banking. So every tumor that comes out, we try and derive tumor-derived organoids such that we can do multi-drug testing. We have a new pathway in the lab to try and begin to study these and other avenues where we keep them alive outside of patients for periods of time. And then we do the standard, all the sequencing. I would call that sort of bare bones, what you almost have an obligation. Cancer centers have an obligation. Everybody is doing the sort of sequencing part of this. Mm-hmm. And so what we've added recently is we've been using our frozen samples, and we're going to do phosphoproteomic mapping. And there's been recent publications from Dr. Yaffe and our group where, when you do this sort of stuff, you get phosphopeptides, and those can be mapped back to kinases based on his recent publication in Nature. And then we can understand kinases that may be important. Of course, there's a whole slew of kinase inhibitors that exist. And so we think this is going to be an interesting way forward. in addition to what's already been done with banking and transcriptomics and genomic sort of work. But every time a tumor comes out at the NIH, there are a lot of things done with it. But I would say tumor banking is sort of standard. And if you're not doing that, you're at least probably not doing what everybody else is doing.
Yeah, and I'm pretty sure that Dr. Fojo and Dr. Krishnasamy also have banking. So I think the banking, this is another reason why it's very important to be in an expert center, because we do research and we're actually interested to derive some idea from the genetic studies and then apply, hopefully, precision medicine. A lot of questions about genetics and how to target right patient with the right medication. The only way we can do that, if we have tissue, we have cell lines, we can make mice and do this research. So just in short, I know Stanford has banking, Hopkins has banking, Michigan, MD Anderson, all of the big centers have banking, of course, University of Colorado, so NIH. So that's great. I think this was a great session. I want to thank all of our speakers, and I will go back to Amanda. Nice seeing everyone.
Thanks, everyone.
Thank you.
Hi. Okay, so we are going to take a very brief break, kind of recombobulate, and we'll be right back.
Hello. It is my great privilege to moderate this next portion of our conference today, and thanks again for coming back to join us. it is truly a privilege for me to be among such greatness here with Dr. Fojo and Dr. Del Rivero, who probably need no introduction, it sounds like, based on the videos from before the conference. But please allow me to introduce Dr. Fojo, who's going to give the talk about medical management of metastatic disease and the indications for radiation treatment. He is a professor at NewYork-Presbyterian, Columbia University, Irving Medical Center, and has a long and distinguished career, initially getting his MD and PhD from the University of Miami and serving as a principal investigator at the NCI. He's also served as the program director for the Medical Oncology Fellowship Program at the NCI. So this has given him the opportunity to influence more than 350 medical oncologists. So we know that he has a great history of caring for patients with ACC, and I feel privileged to introduce him. Tito?
Hi, thank you. Thank you, Julie. Thank you very much. Can you hear me?
Yes.
So I'm going to do something different. I'm actually not going to use any slides. And I told Shannon and Pat that I would basically approach this as if you were to come and see me. The only problem is that patients come to see me at multiple intervals and also at multiple times in their history. I have patients who come when they're newly diagnosed. I have patients who come when they've been newly diagnosed, had surgery, and now want to know what to do. I have patients come when for a first time the disease is shown to be elsewhere in their body, and patients who come when their disease that was elsewhere in the body has progressed and they need help. So a theme that has recurred through this is that this is a disease, like many diseases, that requires a multidisciplinary approach. And by that we mean that you need a medical doctor, an interventional radiologist, a surgeon, a radiotherapist, an endocrinologist, and likely other individuals as well. And so for that, what I find is that anybody who gets interested in this disease then really gets invested in this disease. So most of the people that you will encounter in a medical center where there's sort of a group of people taking care of adrenocortical cancers all find that this is a very interesting and challenging disease, and so are very devoted to it. So let's start at the beginning. So when you first present, the imperative is to see if surgery can be done. And that is, without a doubt, the most important thing that be done. And, you know, we talk about it. You really need to find a good surgeon, someone who's been trained in oncologic surgery and knows how to do that properly. This is your one best chance to have it done. And it's sort of been alluded to. There's the possibility that you might be offered laparoscopic surgery. You should never do that. And the reason is that laparoscopic surgery is done because small adrenal tumors that are not malignant are incredibly common, and they're incredibly commonly removed. And when laparoscopic surgery became available, and this could be done very easily, even as an outpatient, doctors started to do a lot of what are called removal of incidentalomas, meaning a tumor incidentally found during a scan for another reason, for example. And they began to do these laparoscopic resections, and then they feel very comfortable with it, and they say, well, I'll just remove that one. But laparoscopic surgery should not be done. And I think at any ACC site, that should be there at the top, because someone who has a new diagnosis may come looking for you. Make sure they know way ahead of time that laparoscopic surgery should not be performed. Dr. Hernandez alluded to this. That is, he talked about tumor spillage, tumor rupture. Laparoscopic surgery is the other thing that leads to widespread of the disease in the abdomen. While he was talking about peritoneal disease, the peritoneum being the lining of the inside of the abdomen and what covers also all of the intestine that is in there. And then this tumor comes to lie on there. And there's no doubt about it. But that laparoscopic surgery leads to that. You will run into someone and say, I'm a really experienced laparoscopic surgeon. That doesn't happen to me. It happens to everybody else, but never to me. I don't think anybody has perfection in the approach. and it's better to get a open surgery than a laparoscopic surgery. So that's the beginning. Then I see patients who come after they've had the surgery performed. And then the question at that time is, what do I do next? And there's been also references to the fact that it's a shared decision between the patient and the doctor. You know, there's the whole spectrum from the patient who wants to do very little, do as little as possible, and try to go back to their normal lives, although it has to be a very adjusted normal life, to those patients who feel they need to do everything. I don't want to leave any stone unturned. They won't be able to live with themselves if eventually there's a recurrence and they did not do A, B, or C. So on the one hand, I may have a strong opinion as to what should be done or not done, but when I don't have a strong opinion, I let that patient feeling permeate my decision and my discussion with them. So on the one hand, there's do nothing. Certainly if you've had a small adrenal tumor removed, then all the pathology suggests that it was well behaved. Watching may be enough. And by the way, how do you watch? I routinely do scans every 3 months the first year, every 4 months the second year, every 6 months the third and fourth year, and yearly thereafter for however long I do it. So that's one thing you have to build into then, is my life is going to be changed because I'm going to have to go get a scan and get anxious about it and worry about it every so often. But regardless, if you just choose to watch, or if the recommendation is you just need to be watched because it was a small tumor, it didn't look all that bad, then you still need to do that. Then the other things that usually come into play here are mitotane, yes or no, and there was some discussion about this earlier already, and that remains the decision that is one that you have to listen to what the doctor has to say and make a decision. I always do point out that mitotane, of course, I've never taken it, and I should have, but I haven't. Okay, I know it's a difficult drug, but I have many, many patients who are on it for many, many years. And you can find a place in that regimen of mitotane where you can tolerate it for a long time. And for sure, the only ones that go online to complain about mitotane are those that had difficulty with mitotane. Those that do well, don't bother doing that. So going online sometimes gives you a very skewed picture. And again, I'm not belittling mitotane. Mitotane is a difficult drug to take. And what makes it difficult is you have to take it every single day. You know, it's unlike chemotherapy where you get it, and for a couple of days you might not feel well, and then you quickly recover. Mitotane, you can't expect to quickly recover from that noisy, from that annoying side effect that you may have, because you're going to have to take it the next day, and the next day. But mitotane is a valuable drug. Does mitotane kill adrenal tumors? Actually, it does in a small percentage of patients. And actually, in the modern era with scans, we have clear, unequivocal evidence of patients who had visible tumors start on mitotane and the tumor disappears. So it does that. But in the small minority of patients, I think most of us would agree that what mitotane does is it can delay the growth of the tumor. And that, to my patients, is often something that I think will be very valuable, and they'll hear me tell them that I want you to begin mitotane because I think there's a very high likelihood of recurrence, but you've just been through a really major surgery, and I don't want you to have to go through another major surgery in 3 months or 6 months. We would both agree, I tell the patient, that if we can delay that for a year and a half, it'll be an easier thing to do at that point than it would be now. And so mitotane has that possibility as well, to delay recurrence. Earlier on, the point was made of mitotane. What it does best is block hormone production. So if you have a tumor that blocks hormones, you get started on mitotane, because having hormones is bad. We know that those who have functional tumors do less well than those who don't have a functional tumor. So we do that. And that would be the other thing. So that's the mitotane. The no mitotane, the yes mitotane, because we want to delay the recurrence and it's a tumor that didn't look so good. And yes mitotane because you've got a functional tumor. How long do you take mitotane? I get that asked right away, and I always tell the patient, ask me in 2 or 3 years, which is a way of saying that several years will be a minimum. And whether you stop at 2, at 3, at 5, or longer, depends on the patient and the clinical scenario. And again, Dr. Hernandez made that point very well over and over again. You all have a very rare disease and you all share a lot in common, but at the end of the day, you're also all unique, very unique. So it all depends on how you've gotten to where you've gotten and what's happened before that incentivizes us to make one decision or another. The other thing is, well, I've had surgery. Should I have radiation? So you're going to get a lot of opinions on that. My opinion is strongly that unless the pathology shows that, oh, there was a positive margin, it appears that somewhere tumor was cut through as the tumor was being removed, and we know for sure some tumor was left behind. Unless that's the case, I do not advocate giving radiation. All that radiation can do is control the local area to which it's being applied. And indeed, if you have a recurrence, we want a really qualified surgeon to go back in and remove a recurrence. Then we can think about radiation. And although the good surgeons will tell you it doesn't matter that there's been radiation, there's no doubt that if you've had prior radiation, it makes a subsequent intervention by a surgeon somewhat more difficult. So I'm trying to leave the surgeons the opportunity to have as clean, as pristine a field as possible. And then finally, so we talked about mitoting, we talked about radiation, and then finally, what about chemotherapy? So as alluded to, there's a trial going on where chemotherapy is given after the treatment, the surgical resection has been performed. I generally don't advocate that. And the reason is that if you don't have disease, and we're trying to kill microscopic disease, although, as I said, for those who want to do everything possible at the beginning, this is a very attractive option. I don't want to leave any stone unturned. But if you don't have disease, it's very difficult to monitor whether or not the therapy is bringing you benefit. And actually, that therapy is actually one that you're going to have difficulty with. And it feels much better to continue the therapy if you know that the tumor is shrinking and not that it's growing. And when it's microscopic disease and you're assuming I'm going to kill it, then you're unable to know whether the tumor is shrinking or not. I would point out that this type of therapy, which is called adjuvant therapy, is used widely in oncology, in many other diseases. It's very commonly used in breast cancer. The benefit that it brings is very little. In breast cancer, over and over again, when you look at the data, you have to treat 30 patients to get benefit from one, meaning, and sometimes even 40 patients. It's something that brings about a little bit extra benefit, but not anything dramatic. You should never think, I got adjuvant therapy, now I'm done, and I'm going to go ahead with my life. I did everything that needed to be done. Even in that circumstance, the chances that it's going to help you is likely going to be not so great, because that's the way it is in all other diseases. So then that's chemotherapy, which we then get to the setting of someone presenting with metastatic disease that has gone beyond the confines of the adrenal and the adrenal bed. Now, this can be at the time that they initially present. They might present with a large adrenal mass and disease in their lungs, in the liver, maybe the bones. The bones is a site that not that frequently is involved and more frequently is seen after the patient has had the disease for a prolonged period of time. But the patient presents with metastatic disease, either with a primary tumor still in place or after a surgical resection. What do you do at that point? On that, I have a very strong, firm opinion, and that is that you get chemotherapy. And you get chemotherapy with EDP. And why do I say that? So a lot of patients come, it's easy to criticize chemotherapy. Oh, everybody thinks it's awful. It's hard. Everybody knows somebody who had a difficult time. It's true, but it's effective. And then someone will say, well, but the response rate for EDP was only 23%. Only 23% of patients derived benefit. Actually, what did those 23% of patients had? They actually had shrinkage of tumor to meet our definition in clinical trials of meaningful shrinkage. What they had was 2/3 of the tumor disappeared. Okay, 2/3. In one dimension, it's 30%, but volumetrically, it's 2/3 of the tumor has disappeared. That's a meaningful amount of tumor reduction. But the more important thing is that Many more than the 23% had tumor shrinkage that was also valuable. And what do I mean by that? So getting down to our definition of a response is nice. You have to go down. We currently do it by just measuring one dimension. You have to shrink by 30%. If you get 25 or 26 or 27 or 28% shrinkage, even 29%, you don't count. You're counted as a non-responder. You're not a partial or complete response. But if you're dealing with someone that has a lot of tumors, it could be that some disappear. And for example, if you got a lot of lung disease, all of a sudden you may have fewer. Or if you have someone who had a tumor that's in a critical place and can't be surgically resected, it might shrink enough that a surgeon is now willing to do it. So the benefit of of chemotherapy such as EDP is that it not only shrinks tumors and tells you something about the biology of the tumor. A tumor that responds to chemotherapy, immediately you say, oh, this one isn't so bad. We can do things with it, okay? But it also sets you up for other opportunities, okay? It sets you up possibly for surgery, possibly for some interventional procedure, either ablation or embolization. And finally, it sets you up for other possibilities beyond that we can discuss. So the best data that we have was the Pharma trial, 303 patients internationally who got EDP, and it's a very effective therapy. Now, there's patients who want to avoid chemotherapy at all costs, and they turn to, in this era of immunotherapy, to immunotherapy. I have a lot of difficulty with immunotherapy. And the reason for that is that I really haven't seen such good results with immunotherapy. I don't administer at the beginning, but I routinely see patients coming who have had it administered and it did not benefit them. The largest trial of immunotherapy is published. The response rate was 8%. So why is that? Well, there is a fraction of patients who, no matter what disease they have a lot of changes in their tumor, changes that make the tumor look foreign to your immune system, and which can be then killed off by the immune system. So in all cancers, you get some responses to immunotherapy, and in the majority, you identify these as those patients who have these tumors. As regards to adrenal cancer, there are certain inherited illnesses that can lead to adrenal cancer, and these tumors can have a lot of mutations, a lot of changes that'll make the body see it as foreign. Where did that come from? I don't recognize that. And that then in those patients, immunotherapy will be effective. But in the majority of patients otherwise, it seems to have very limited activity. And I'm also concerned because I have seen many patients in whom the disease seemed to accelerate and become more aggressive after receiving immunotherapy. Therefore, my practice, and the patients who have seen me know that, is that I prefer to defer that to a later time and not usually right at the beginning. So again, when you have your surgery done, routinely now, it's done everywhere in the world where there's a good academic center and where there's resources. And fortunately, for most of us, we live in a world where there are those such resources available. The tumor will be sent out for molecular analysis. Now, when that's done, your doctor may talk to you about, well, we might find the mutation that your tumor has for which we have a drug. Possible, but the chances of that are very, very, very low. What has become more of a chance is that you'll find some indication that your tumor has a good chance of responding to immunotherapy. And I talked about adrenal cancer. There's a syndrome called Lynch syndrome that you inherit from your parents. Lynch syndrome then is associated with a lot of mutations, and then the tumor is seen as foreign by the body and can be attacked. In cases such as that, immunotherapy would be indicated. But I would point out here that immunotherapy would be given concurrently with mitotane and other medicines to reduce any hormone production by your tumor, because the hormones that adrenal tumors produce and which are very plentiful in the environment of the tumor, are actually lethal to the lymphocytes, the immune cells that need to come into the tumor to kill the tumor. So you have to be sure you totally eradicate those to the best of your ability. So there's chemotherapy, and then there's also, when you have metastatic disease, surgery, interventional radiology, and we haven't heard very much from radiation therapy, so I'm going to mention that. So it is clear that surgery has a role, and it hasn't been mentioned, but Dr. Hernandez alluded to it, and I disagree with him on that. And that is that anytime you go to do surgery, you need to be planning to eradicate all the tumor and to remove all the tumor. Adrenal cancer is not one of the diseases, and we have several in oncology where what we call debulking, which is removing the majority of the tumor, is beneficial. In adrenal cancer, I've never seen anyone in whom debulking brought much, if any, benefit. So I always demand from the surgeon that we're going in with a plan to remove everything. We're looking at the scans and we think that this can be done. And so consequently, a resection that is planned that won't be total is not one that should be done. Of course, once you get in there, you might find that things are different. And one of the things that we find that is different is you'll find a lot of these peritoneal deposits that Dr. Hernandez was talking about. And in those cases, I strongly believe that high pick is of value. This high pick is high is intraperitoneal, intraperitoneal chemotherapy, and it's heated. That's where the H comes from. And it's something that I find to be of value, and I encourage it in patients. And the reason for that is that the majority of the tumors that are sitting on the peritoneal surface, when you look pathologically, they don't have very good blood supply. And the reason is because, to a certain extent, they live off of what they're floating in and can survive on that. And because they lack good blood supply, they're really not vulnerable to chemotherapy. I have never, ever, ever seen a peritoneal mass recede with chemotherapy. So it's either has to be removed surgically, or if it's microscopic, has to be treated with topical chemotherapy. Then the other possibilities that were talked about are the ablation procedures, radiofrequency being the oldest, cryoablation, and microwave ablation, and then embolization. And these are procedures that, to me, are comparable to surgery, provided that they can be done. So when I first started using these procedures more than 20 years ago, I asked myself, is this a surgical possibility here for this patient? And if the answer was yes, we would do surgery in these circumstances. I now had the option of turning to the interventional radiologist and saying, do you think you can ablate that or embolize it? And if they did, then that becomes a substitute for surgery, something that is not as invasive. With regards to the lung, you can even do some ablations there. And what has been described with regards to the lung were two very important things. Number one, it has a slower growth rate usually than other parts of the body to where the tumor may have metastasized, and certainly slower than the tumor that metastasizes to the liver. And number two, that they can be very successfully resected. In 1996, we resected 87 lung metastases from one of my patients, and she's still alive. So it's something that is very effective. Generally, in my practice, I counsel patients, let's wait. And it's a very uncomfortable situation to be in. But I want it to be, I tell them that when we go in, we've given everything that was there a chance to declare itself so we can get as many things as possible out of you. And then when they're going to surgery, I tell them they're going to have one side and then the other, and they'll probably have at least one other surgery because we can't be perfect. But patients do find surgery more attractive than chemotherapy or anything else because there's nothing that feels good than to have a surgeon tell you, we got it all and we removed it. The best place for the tumor for any patient is anywhere but in my body. I want it outside of my body. And surgery has a place, but again, it has to be undertaken with the plans to remove everything or to have a plan for whatever you don't remove. And number two, it has to be done in due time. And it sometimes makes patients uncomfortable to be sitting on lung metastasis and not doing anything about it. And in fact, in my experience, I've never seen any evidence that that went anywhere else. And so we go ahead and we take our time and we make the right decision at the right moment. And then finally, a word or two about radiation therapy. The thing that has changed the most in my career has been radiation therapy. Those who do radiation therapy have become incredibly sophisticated. So like 10 years ago, we would never radiate a tumor in the liver because we couldn't give a high enough dose without destroying the surrounding liver. Now radiation therapy is an option for liver disease. They actually have gotten so precise that they can give it to a very small area and some margin around it at incredibly high doses that the rest of the liver would not tolerate. So we used to use radiation therapy primarily with patients with very advanced disease, patients that we knew were going to die, and had tumors someplace that was causing them pain or discomfort. And I never had a case where the radiation therapy didn't work. Unfortunately, many of those patients then were patients who would die in the not too distant time forward. But now we're finding that actually radiation can work for some patients incredibly well. And we now have several patients out several years from radiation without any evidence of recurrence. So that basically takes us through the entire course. When you see a doctor, no doctor should tell you that they're going to cure you. And I think all of my patients will always be able to tell you, I never used the word cure. I always say that I want to prolong your life. And eventually we prolong it enough that you've lived so long that you might be cured. But initially that is our goal, to prolong your life. And that means that whatever happens, we're going to address and then try to once again prolong your life. And then address and once again prolong your life. And in some cases, we seem to outrun the tumor. And the tumor then just stops. And we then get into a situation where you live for a very, very, very long time. So when you first have the diagnosis, don't be discouraged. Everybody's different. That case has been made. There's nothing that I can tell a patient by seeing them that they're going to do well or bad. Only time is going to tell us. And Dr. Alexander talked about the advantage of having multiple scans and then knowing something about how quickly this is growing or not. That's what it gives us, a lot of information about you, the unique patient that is you. And also remember that a recurrence is not a life sentence. A recurrence is a call to action. And we have a lot of things that we can do, and we do them. And with all these things, we're prolonging your life and prolonging your life. And then eventually, in some cases, we prolonged it very long, and maybe we did cure you. So that's it. You're an amazing group of patients. I can't tell you how much I enjoy working with all of you. And so don't be distressed that, it's a rare disease. We still feed off of other research that is done in more common diseases. And so we don't not have any research in adrenal cancer. Research that for other cancers benefits us as well. And don't be distressed if the doctor you see says, I've never seen one in my life. Just go online and figure out who you should go see. And then you'll be in good hands. So thank you for this opportunity. And I wish you all the very, very, very best.
Thank you, Dr. Fojo. That was a fabulous and very practical talk, and I can see why you make such a difference in the fellows that you have taught over the years. So I'd like to introduce Dr. Del Rivero, who to many of you needs no introduction. I think her email is all over the chat, so she's going to be very busy over the next days, I suspect. She's a physician scientist in the developmental therapeutics branch and the principal investigator of the natural history study for neuroendocrine neoplasm and adrenocortical carcinoma. So she is the head of multiple clinical trials at the NIH. She is exceedingly helpful and communicative to work with as a physician from afar, and I'm grateful to call her a friend. Thank you, Heidi.
Great. Thank you so much for the kind introduction. I'm going to share my slides. Okay. Can you see my slides?
Would you rather share your own?
Yes. Would that be okay?
No, that works perfect. Here you go. All right. You are all set.
Oh, and you can see it, right? You can
Yep,
see the
yep.
slides. Okay, great.
You're good.
Okay, great. Thank you so much. First, it's so difficult to follow Dr. Fojo. He is amazing. I do want to share that he is the reason why I decided to become a medical oncologist. He's the reason why I'm also decided to study this and see patients with ACC. His career has been amazing. He has been seeing patients with ACC for many, many years. His knowledge is something that I don't think no one can really, has the amount of knowledge that he has because he has so many years of experience. And I always, when I was listening to his lecture, I was not even blinking. I was paying attention. I just want to kind of like get all the information and learning. And because he's the wealth of knowledge that he has is something that I can never be like him. And I just to let you know, Dr. Fojo, thank you for giving me the opportunity. If you're listening, I hope you're listening to follow you, to shadow you, thank you for being my mentor, and thank you for giving me the hope that I'm sure many patients feel as well, because you give them hope and you have changed how we manage ACC. The surgeries that we do at the NIH wouldn't be possible without Dr. Fojo. The interventional radiology procedures that we do, it wouldn't be possible with Dr. Fojo. So Dr. Fojo definitely paved now how we see patients with ACC, and now we're learning that a lot of these patients can live a long life. So, and I have to say thank you, Dr. Fojo, for giving me the opportunity to continue learning for you. I just want to say that. With that, I'm just going to share my slides, and I hope you can all see it. So I'm going to discuss about clinical trials. First, I want to discuss what clinical trials are, and then after that, I'm going to discuss what clinical trials are available for adrenocortical carcinoma. First, let me give the definition of clinical trials. Clinical trials are research studies that test how well new medical approaches work in people. Through clinical trials, doctors find new ways to improve treatments and as well to improve the quality of life of certain diseases or tumors. Researchers design cancer clinical trials to test new ways to treat cancer, find and diagnose cancer, prevent cancer, and also manage symptoms of cancer and side effects from this treatment. I think one of the questions that I was looking at in the chat is about quality of life. How can we improve quality of life? We need to learn about that. We need to learn what is effective therapies. And at the same time, we also need to learn how we can improve the quality of life based on the tools that we have. And it's something that we certainly I'm going to discuss here, and we can always discuss offline as well. Clinical trials are the final step in a long process that begins with research in a lab. Before any new treatment is used in people in clinical trials, researchers work to understand its effect on cancer cells in the lab and in animals. They also try to figure out then what can be the possible side effects. Now, this is what are the different phases of clinical trials. And the reason why I'm saying this is because different patients, when I see patients with ACC, a lot of my patients has talked to me and asked, well, my doctor so-and-so recommended this clinical trial, and sometimes may not be specific for ACC, but I think it's important to understand what are the different phases of clinical trials. So first, everything as we discussed earlier starts in the lab. So in the lab, we're trying to test different ways of how a specific treatment can work in cancer. Then after that, once we see a signal and we see some evidence that a certain drug may have some activity, then we move it to the clinic. So the first phase of the clinical trial is phase 1, and the goal of the phase 1 is to determine if the drug is safe. what is the dose that is needed to move then to the phase 2 phase of the clinical trials. But just to understand, phase 1 is safety of the drug. And that's usually testing a small group of people. Phase 2 is to determine further safety. But at the same time, we're also trying to understand the efficacy of specific dose and as well check for efficacy in certain tumor type as well. And that's usually given in a larger group of people. Phase 3 is to once we confirm the efficacy of the drug, then we move to the phase 3 before it can approved by the FDA. And that's usually given to a larger group of people as well. And as we continue always monitoring long-term safety as well. Even earlier today with our representation from Pharma, they still, even though Mydotyn has been approved by the FDA, they still monitoring long-term safety as well. And every time they hear a possible side effect, they also look into that as well. And we're always trying to understand more about this drug in the long term. Now, I always tell my patients knowledge is power. And I always tell my patients as well that whenever there is a recommendation from any of your treating physicians, or whenever there is want to participate in a clinical trial, it's important to ask questions. It's important to ask the questions to your treating physician and understand why we are recommending a specific therapy over others. And I think throughout the day today, we learn about what is the different approaches for adrenocortical carcinoma. And I understand that maybe for some of us, maybe a lot of information. I understand that for some of us, it's something that, like having understanding maybe a little bit more complex, or maybe some of us didn't learn that all these possible therapies can be indicated, and not in all patients, but it can be indicated. And as Dr. Fojo also mentioned earlier, surgery, he has seen patients as surgery can be an option for patients, radiation, intervention radiologies. And it's always important to ask as well your doctors, why these therapies over others, and always ask to your doctors what are the possible side effects, and always ask to your doctors why we're recommending something. And I know that some of us don't want to ask questions because we're afraid of the answers, because we don't want to and knowing, I'm from Mexico, so sometimes my parents are afraid always whenever they go to the doctor to ask any questions, because they don't want to make it sound like they're against what we recommended. But I always say my patients ask any questions, and knowledge is power. That said, whenever we do a clinical trial, it always we want to answer a question. And that's what we call primary objective of the study, meaning we wanted to answer the most important question of why we wanted to develop a clinical trial. And it could be either if by giving this treatment, can the tumor shrink? If by giving this treatment, is it going to stabilize the tumor for a long time? That's usually what we call the primary objective, is the most important question that we wanted to answer on a clinical study. And the secondary objective, that's other questions or other relevant questions of the same study that we wanted to answer by study a specific drug in a specific tumor type. Now, so I wanted to discuss what are the challenges in ACC. So as we all know, is one of the challenges is that we only have one FDA-approved agent, and that's Mydotyn, and that has been since the 1960s. So since then, we haven't had any other approved agent for ACC. And some of the questions that you ask and is in the chat, and some of the experts also answer some of these questions, is also to understand how long a treatment should be continued. So we also wanted to understand what the challenges is, what's the group of patients, a particular option should be used. I think this morning we discussed possible options from Mydotyn, surgery, radiation, intervention radiologies with liver ablation, embolization, lung surgery, and all the options, radiation and systemic therapies, and all the options that Dr. Fojo described. But sometimes, the question is like, when do we need to use a specific therapy? That said, I do recommend my patients that it's important to see someone who has expertise in adrenocortical cancer. And I have to say, Dr. Fojo has in my mind has the most experience in ACC and has seen the most patients in ACC, and he definitely has a very good perspective of how the different management of adrenocortical carcinoma as well. Now, patients with ACC and their family face unique challenges. One of the things is because sometimes it can take a long time of diagnosis, and sometimes when the ACC is diagnosed, it's identified in advanced stages. And I think we discussed about that earlier. One of the questions that I saw in the chat is about functional tumors versus not functional tumors. Functional tumors are the ones that produces excess of hormones, and because this excess of hormones can cause symptoms, the most common hormones that we see is cortisol. And Dr. Hallanger and Kiseljak-Vassiliades discuss what is the different characteristics and clinical manifestations of a patient with ACC producing cortisol. Sometimes this excess of cortisol can definitely cause symptoms, but as we all know, often ACC may not causes hormones. Yeah, they're not. They're diagnosed more in advanced stages. Most medical centers has limited experience with this tumor, so patients often has to search for experts and sometimes require extensive travel outside the home region. And because we don't have really standardized treatment guidance, I'm sure what I recommend may be different from some other institutions, or, and Dr. Fojo as well may make different recommendations. That can sometimes create uncertainty and search for answers, and sometimes patients can feel isolated because of that. Now, on the other hand, ACC researchers also face hurdles to develop cures. This is, as we discussed earlier, and you have heard from many of the experts, is it takes a long time to accrue patients in clinical trials, being a rare cancer. Multidisciplinary care is needed for patients living with ACC, and that's something that maybe not every institution may have the opportunity to have all the expertise needed for this tumor type. Sometimes this lack of coordination between teams creates silos, and that limit efficiency into other clinical trials as well when the time is needed. But also, as Dr. Kiseljak-Vassiliades has discussed earlier, and that's one of the works that she has worked, and I have to say, I collaborate with her because she established the first ACC set lines as well as patient-derived xenografts, when it's basically when the tumor is placed into the mouse and they let it grow, because of what she has done as well, is going to help us understand more about drug testing, and that's something that we're doing, and we're collaborating with her as well. And also, being this is a rare cancer as well, sometimes fundraising can be challenging. There is less sources of grant funding, very different from other breast cancer or colon cancer, that they have different sources for grant funding. We have not seen the same for ACC, and a lot of our ACC researchers struggle because of that. And without this research that is needed, so we cannot accelerate the needed treatment options for these patients, and that's some of the struggles that even our ACC researchers faces as well. Now, I have to say I'm very fortunate that here at the clinical center, I'm the principal investigator of a natural history study for neuroendocrine tumors as well as adrenocortical carcinoma. I have to say I don't like to take credit for any of this because a lot of this has been already, Dr. Fojo has established the platform for us to do all of this work. But I'm hoping that some of the struggles that I just discussed earlier, I hope that this study can help answer some of these questions. We discussed, somebody asked earlier about tumor banking too, and this is a protocol that allows, and Dr. Hoang and Dr. Hernandez also mentioned about this, but that this protocol allows for tumor banking and also to do future analysis as well. At the same time, this protocol allows me to follow long-term and understand more about the natural history and the biology of adrenocortical carcinoma. And the reason why I'm doing this study is because some adrenocortical carcinomas needs to group them with the neuroendocrine tumors, but we now know that it's not necessarily a neuroendocrine tumor. It's a tumor that produces hormone, but we know it's not a neuroendocrine tumor. So that's why I make the differentiation of this natural history study for neuroendocrine tumors as well as for ACC. And the idea is to be able to characterize the natural history of these studies, the data that include as part of being as being part of the studies, all the clinical information, the demographics. We also wanted to understand what is the patterns of disease growth. So why some patients, the tumors grow more rapidly, but there's others that may grow more slowly. We also wanted to understand the response or lack of response to different therapeutic interventions, because as we know, sometimes what I'm encountering is, and maybe Dr. Fojo can comment later as well, is that we have, in terms of the therapeutic options, there are different therapies, but not everyone is able to have the same response. And we wanted to understand why we're seeing that, and also correlate, in terms of how long even these different therapeutic interventions that we discussed earlier and also discussed by Dr. Fojo, how that can also help us, stabilize the tumor growth or live longer with the diagnosis. Now, why this is important, because a natural history study, why? Because I know that this is a question that I'm sure some of you may ask, because they ask about tumor banking. And one of the reasons is because this study allows us to follow patients long-term. As being part of the study, researchers will also collect details of the patient medical history, allow us to collect tumor samples and other clinical data as well. And the reason why we wanted to do these studies is because by learning about this specific tumor type, in this case, adrenocortical carcinoma, and follow these patients over long term, they can help us understand how cancers form, growth, and spread, and also if there is any genes that may cause cancer to develop, and is that anything that may occur in family. We can also learn clues to help hopefully prevent cancer, and that's our goal, and that's why we're doing this. At the same time, we wanted to learn clues to help develop new therapies and effective therapies for ACC. So I think some of you ask about how we see patients at the NIH and how do we the available clinical trials within our institution. So and this is within the NCI. NCI is only an institution within many different institutions at the National Institute of Health. And within the NCI, that has different branches within the NCI. We have the Center for Cancer Research, and that's the institution that allows us to see patients in the clinical center. So usually the patients contact us directly. So I'm not going to provide my email because I do want patients to contact me directly. There is also a referral coordinator as well, a number, but I will just prefer if anybody have an interest to be seen at the NIH to contact me directly. So how patients can be part of our studies at the NIH or the NCI is to have a diagnosis that is confirmed by your own doctor. So and we have an interest to study and learn about adrenocortical carcinomas as long as we have the diagnosis. So it's highly suspicious based on scan and hormonal evaluation for ACC. That will be an indication for a patient to be referred to the NIH. And because we have an interest to study this tumor type long term. We review all of the records, and then based on the information, we can provide a consultation, and patients may not necessarily need to come to the clinical center, or we invite the patient to come to the clinical center to have an official screening visit to then be considered for our natural history study. Once enrolled in a clinical trial in the NCI, care at the clinical center is free. And for more information, this is the website, is www.cancer.gov, which you can find more information about the clinical studies within the NIH. So what is the process? Patients that wants to be seen at the NIH or the NCI is either the patient or the referring physician refer the patient to us. We collect, and it's usually they contact me directly, but we collect all the clinical information, pathology, and imaging results. Once we have that information, we then have a discussion with our multidisciplinary experts. You heard a few of them today. So I'm the one, our team is the one who collect all the information, the pathology, the imaging, the report. Once we have that information, then with our team, we discuss it with our surgeon. You heard this morning about Dr. Hoang, you heard this morning about Dr. Hernandez, and also Dr. Krishnasamy used to be here at the NIH. Now he's working with Dr. Fojo. But here at the NIH, we also have an intervention radiologist, Dr. Wood, as well, who also see patients with ACC. We discuss the cases. And like you heard earlier by Dr. Dr. Hoang as well, and by Dr. Hernandez and by Dr. Fojo, it's important to have these discussions to then guide us what would be the best therapies or options for our patients. Once we have that information and we have a plan, then we discuss that with our patients or referring physicians, and there are different ways that the patients can be also enroll in studies at the clinical center. They can be enrolled on there is what we call a standard of care protocol, and that protocol allows for patients to have surgeries here at the NCI, and that's a protocol that Dr. Hernandez is part as well. He also have another protocol that allows tissue banking as well for surgical specimens, not specifically for ACC, but for other surgical specimens as well, because he also does do other surgeries of the pancreas and GI tract and so forth. And also, if some of the patients, they can also be co-enroll, meaning they can enroll more than one study at the clinical center, and that's where we offer our natural history study to follow those patients long term. But if there is treatment available at the clinical center, then we then provide that information to the patient of treatment studies. We don't have right now, we're working now, and hopefully in the next few months, we're going to have clinical trials specifically for adrenocortical carcinoma. One of them is, as Dr. Hernandez discussed earlier, this is a study that I'm very excited that also I'm working with Dr. Hernandez about that, but that's a study specifically for liver metastasis, and that's something that or liver lesions related to ACC. So I'm excited to work with him on that study, and that's also coming up in the next few months. And similarly, we also have another study in development as well for those patients that surgery is not an option. So then we have a study as well that will target patients specific with ACC. Now, how is a patient need surgery? So then I talked to Dr. Hoang, I talked to Dr. Hernandez, and then as you can see, there is a process for that as well. So once, and that's when somebody was asking about banking, is that if Dr. Hoang does surgery of the lung, or Dr. Hernandez the liver, or resecting any recurrence, usually what we do is that we collect a small piece of tumor, and that's when we collect it for banking for future analysis, but we also do real-time analysis as well. And that's where Dr. Hernandez has very exciting research as well going on with the different tumor types, but including adrenocortical carcinomas and other neuroendocrine tumors as well. But what we do in the branch where I am, and I'm very fortunate to work also with very wonderful people that does the lab work, is that we're trying to grow organoids, meaning that we take a small piece of tissue and then we let them grow in a petri dish with a very specific media. And the goal is that by letting them grow, then we can do different drug testing. And that's what we're doing about trying to develop novel therapies for ACC. We're also collecting all the genomic data from the tumors. And as Dr. Fojo explained, we don't have until now anything that we can target with treatment, but I'm trying to learn by extracting all the genomic data with the DNA and the RNA, and we put it on this tool to understand what molecular profile the tumor may have and correlate that with treatment response, or whether we can find any markers of which patients may respond to certain therapies, or markers that may help me understand more about the biology of these tumors as well, and which tumors may be more aggressive. And that's one of the things that we're doing as well. I'm also in collaboration with my pediatric and adult rare tumor network. As we know, adrenocortical carcinoma also affect kids, and that's something that some of the efforts by the pediatric oncology branch, and that's why I'm not a pediatric oncologist, but I do see the pediatric ACC with the group with the pediatric oncology branch, and there is other researchers and investigators that are also dedicated to understand more about these tumors, to understand what is a tumor immune microenvironment, be able to develop other models that to then be able at the end to be able to develop better therapy. So this is, as you can see, is not I'm not doing this alone. So as you can see, it does require a village to be able to do all of this, and we collaborate also with Dr. Kiseljak-Vassiliades. We also I've always have Dr. Fojo. I'm always talk to Dr. Fojo, so I'm grateful that he can also guide me in some of this. So I have to say this is a team effort, and and we're working tireless to be able to develop better therapies for ACC. Now, in terms of ongoing right now clinical studies, and this is something that is available in different centers within the United States, there is a study of mitotin that are given in combination with chemotherapies. Either patients are what we call randomized, so it can either be there are two different arms, two different group of patients. Either they can be a mitotin alone, or they can be a mitotin in combination with chemotherapy. Sometimes, and as Dr. Fojo may have mentioned earlier, sometimes when a patient asks me, especially with the high-risk ACC, and with high-risk ACC, those are the ones that have a high Ki-67. Earlier, the Ki-67 is a number, it's a proliferation index. It tells me how the cells are able to divide under the microscope, and other also characteristics. But the question that this study would like to answer is, by doing this in high-risk patients, ACC, is there is a benefit? I don't know the answer, and sometimes patients come and ask me, can I do that? And I think if the patient have an interest to be enrolled in a clinical study, I think that's something that the patient needs to make the decision. But as we know, and I'm also in agreement with Dr. Fojo, it's hard to recommend this without having the data or the information that tells me, yes, this is going to work. But that said, it's always important. You always need to talk to your physicians about what the options are out there, and you always need to ask to your treating physician why or why not, why this therapy is better than the standard. Always ask questions, and even if you may not have all the questions when you go and see your doctor, always write your questions down. You can always ask at a later time. But this is an ongoing, and I will, because I know that we're running out of time, if you have any questions, I'll provide my email. I'm always happy to answer any questions. At the same time, the slides will be available to you if you always want to go back, and if you have any questions, please let me know. There is another study that's ongoing, my understanding. Maybe Dr. Fojo can clarify this, but I think we have earlier discussions about the HIPEC, or hyperthermic or headache intraperitoneal chemotherapy. This study is ongoing at Columbia University. I'm sure Dr. Fojo may be familiar with this. Even though we did a study here when Dr. Fojo was here at the NIH, still, is following the study to have more of a people enroll in the study, so that way, we can understand more about the benefit. I know Dr. Fojo, has a lot of experience on this, and he knows as well why he wants to indicate this type of therapy to patients as well. But that said, there's an ongoing study too of patients that have adrenocortical carcinoma that are confined only in the abdominal cavity, and that's what we mean the peritoneal cavity, the abdominal cavity, and they give surgery and followed by intraperitoneal chemotherapy. And the question that they want to answer is about is a terminology we call progression-free survival. And I'm sure you heard earlier what survival is, but those are the questions. I mean, whenever we do the studies, and maybe at another time I can talk more in detail about this, whenever we do these clinical trials, there are specific questions that we want to answer. And usually the questions are whether by getting this treatment, is this going to help me live longer, if it's going to stabilize my tumors, if it's going to shrink the tumors. So, and of course, a lot of these, studies also correlates with quality of life, and quality of life is something that we are implementing more in our clinical studies as well, because we wanted to understand too, what is the benefit of giving this type of treatments and overall quality of life. There is another therapeutic vaccine. So some of the Dr. Fojo discussed earlier about immunotherapy, went to the indications of immunotherapy. I think there's a lot of unanswered questions, and we're trying to learn of that. That say, we also don't necessarily recommend chemotherapy as a first line, but it's an option that is there. That said, one of the things that we wanted to, and that's overall in the medical oncology field, is to how we can make immunotherapy more effective. And that's one of the studies. It's ongoing on MD Anderson, but it's an international study, and is of a therapeutic vaccine. So, and that's this vaccine who doesn't have a name yet, and it's trying to mimic the microbiome, and by doing that, whether doing that specific way of treatment, could that make immunotherapy more effective? And that's the reason why you have this vaccine in combination with immunotherapy, and this situation is nivolumab, and that's for two group patients with adrenocortical carcinoma, as well as for pheochromocytomas and paraganglioma, which is another tumor of the adrenal gland. So since this is a phase 1 study, so they're trying to determine the safety, the question they want to answer is the adverse events. There are other studies. There are more treatments available in the States for metastatic adrenocortical carcinomas. MD Anderson has a few of them. Michigan also has a few. And as you can see, the studies here are with immunotherapy. One of them is pembrolizumab in combination with mitotaine. And that's open, but not yet accruing. I know that MD Anderson is a site for this study. There is also dual immunotherapy for patients with rare cancers. Personally, it's not something that I necessarily right now recommend for ACC, but I know some of our pediatric oncologists do recommend this dual or 2 type of immunotherapy in patients with pediatric adrenocortical carcinoma. I still feel we're learning from this too. And the other one that is also just opened and is available also at MD Anderson, Michigan, and others is the study of this drug. Is called relacorilant, which is a glucocorticoid receptor antagonist. So it's a blocker of the cortisol production. And they wanted to do it in combination with immunotherapy because they wanted to understand what is the efficacy of immunotherapy, especially in those patients that produce too much cortisol. So what we know is that, and that's also in a standard practice, is like any patient, and doesn't have to be ACC, but any patient that takes an excess, a large amount of steroids, what we call exogenous steroids, that's usually a contraindication for immunotherapy. And the reason why is because the steroids can suppress the immune system. And by doing that, immunotherapy cannot be as effective. So I think this is a question that is an important question, and that wanted to do this in combination with immunotherapy. I think there's still a lot that we need to learn about this. But like I said earlier, it's very important that you discuss all the possible options and what is the treatment available for ACC. Those are the studies in the United States that are available for adrenocortical carcinoma. Always talk to your treating physician. Always ask the question, why or why not? Why this over any other standard therapies? And it's important that you always understand. So whatever decision you make, you're comfortable with that decision. And again, it's something that we're still learning with the ACC. Now, what questions you ask your doctor about a clinical study? You want to be a part of a clinical study. So we need to understand what is the purpose of the study. Why do researchers think the approach may be better than the one that's been used? And that's what I was mentioning earlier. How long will I be in the trial? What kind of tests or treatments are involved? Who can I speak with about questions and I have during and after the treatment? Who will be in charge of my care? So there are very valid questions that you need to ask about the study. You also need to ask questions about the risk and the benefits. What are the possible side effects or risk of the new treatment? What are the possible benefits? And those are the questions that you need to always ask. Questions to ask your doctor about clinical studies. You need to ask about your rights. It's your right to be a part of a study. So you can ask how your health information is going to be kept private. What happens if I decide to leave the clinical study? So you need to ask questions about costs. Which cost do I have to pay if I take part of a clinical studies? Like I discussed earlier, these studies may not be available everywhere in the States. So you need to ask also what is the cost of travel and so forth, and if the insurance company will cover some of these costs. And also who can help answer questions from your insurance in order to cover these costs as well. Questions about daily life. How could the trial affect my daily life? How often will I have to come to the hospital or clinic to get treatment? How far will I need to travel to take part of the study? Will I have checkups after the trials? So those are some of the questions that you need to ask. Like I say, these are your rights. And I always say knowledge, and I repeat again, knowledge is power, and it's your right to be part of any study, even my study with the natural history study. Tips for asking your doctor about studies: consider taking a family member or friend along for support and for help in asking questions or recording answers. Plan what to ask and don't hesitate to ask any questions. Write down the questions in advance to remember them all. Write down the answers so you're available when it's needed, and you can always go back and ask again if you may have any questions, something was not clear. So this is a web page. It's called clinicaltrials.gov. I have to say, I don't think it's a very friendly way, especially for patients. I think that the people who are developing this, how to find clinical trials are aware that it's not necessarily patient friendly. But that said, if you go to this website, you can put, as we can see here on the screen, you can put the type of tumor. You can also type where in the country may be available, and then there will be a series of clinical studies available. That said, I have to say that here at the NIH there is a way to also contact us, and my understanding from other patients is easier. They also provide information about clinical trials. They also provide information about research, diagnosis, and treatment. So that's something that is available for you. And I think those are the resources that you need to have in order to ask any questions that you may have. This is the NCI has it's aware of studies out anywhere in the States. So I think this is a good resource. But moreover, this is my email, and always please feel free to email me. I'm always available to answer any questions as well. And with that, I just wanted to thank you all. I like to thank our true heroes, which is yours, our patients, and our caregivers. I have to say that you are our true heroes, and we're on this together. This is a quote that I like to mention: individually, we're one drop, but together we're an option, and we're here for you, and you're not alone, and we're finding this with you together. With that, this is my information, my email, and please feel free to contact me directly. Thank you.
That was fabulous, Dr. Del Rivero. Thank you so much. I really think that it's so helpful for patients to understand all the different phases in the clinical trials and what questions to ask. That was very excellent information. So I'm grateful that it looks like we have time for a couple of questions. So, oh, good. Dr. Fojo's back too. Great. I think that this was all so very helpful, and I think our patients have submitted a couple of questions beforehand, and I think there are a lot of questions in the chat. So the first question that I have that was submitted beforehand was how concerned Li-Fraumeni patients should be if they have a benign adenoma on the adrenal gland that it might become cancerous down the road.
Dr. Fojo.
No, you can go ahead, Jaydira.
I always rely on Dr. Fojo. I think whenever somebody asks a question, I was like, Dr. Fojo is right here.
So it is concerning. And then what you do is you treat that like you treat any other, or you approach any other adenoma, which means get serial scans and see how rapidly or not it's growing. And then if it's growing faster than you feel comfortable with, then it's time for an open resection. And that's what the problem becomes, that you've got a small tumor and you say, you're gonna have to cut me open to get in here. I'll take that, laparoscopic approach. No, don't do that, because that small tumor open is gonna be cured. Laparoscopic, you have a 50% chance or something of then developing peritoneal metastasis, and that's very, very, very difficult to treat.
Very good, very good. I think this was alluded to on from both of you, which is whether genomic testing can be done in ACC, and I think Dr. Fojo said maybe not helpful unless you're getting CPS, TPS scores. But Dr. Del Rivero, I know you also alluded to that, so maybe you want to take that question.
Yes, I mean, and I do. We get a lot of these questions because it's done for other cancers as well. And please, Dr. Fojo, with your experiences, I have to say, I feel so honored to be in the same stage with Dr. Fojo. I always dreamed to do that, to ever had the opportunity, and it finally came true. So, Dr. Fojo. So, but that said, yes, I mean, I don't think we doing molecular testing is still not for ACC, because even if we do it, there is nothing that we can target that could be of activity or benefit to patients. I have to say, and I sometimes I do talk to Dr. Fojo, because sometimes we have found these mutations that we can target, but unless we have a clinical study that tells me what is the benefit of doing this specific treatment for this specific target in ACC, it's very difficult for me or to make the recommendation about that, because and again, Dr. Fojo has a lot more experience, but I don't think we have seen really a true benefit of doing this in ACC. One of the things, and I would love to know, Dr. Fojo, why this has happened, because I think one time a patient, I'm like, why is that? And is that because maybe ACC, we're trying to understand more about the biology of ACC, but at the same time, I think that ACC has a lot of these genes that cause resistance to different therapies, and that's something that Dr. Fojo nicely described years ago, and some of the work that he did here at the NIH, but something that we're trying to understand. And yes, I mean, to date, even if we do molecular testing, there is no mutation that we can target with treatment, not something that I would necessarily recommend. That say, here as part of the research that we're doing, we're trying to understand more about that. We're doing a whole exome sequence on the tumor and the blood as well, and we're trying to understand whether that can help us understand more, not necessarily more of finding a drug that we can target, and more to help us understand whether we can find a marker that can help me to understand which patients may benefit for certain therapies, or which patient may have a more aggressive course. That's what I can say. I don't know, Dr. Fojo.
Yeah, no, I agree with all of that. But unfortunately, we've not been able to leverage that into a therapy for a patient. I mean, part of it is because those therapies that target a certain mutation usually work in cancers that are simpler than adrenocortical cancer, and wherein that mutation is crucial. And none of these mutations appear to be crucial in cancer of the adrenal gland, which is a bit more complex. And so targeting just one thing usually doesn't get you more. But currently, I think everybody should get get the tumor mutational burden that we talked about,
right,
which indicates whether or not, and then whether or not they have Lynch or something like that, that might incentivize you to do immunotherapy, because in those patients, there does seem to be an opportunity for benefit.
Okay, very good. Do either of you want to comment a little bit more about the use of tyrosine kinase inhibitor therapy with or without combination immunotherapy like pembrolizumab and lenvatinib, for example? There was a question submitted about that.
I'll let Dr. Fojo.
No, again, I mean,
outside of a clinical trial is hard.
Yeah, outside of a clinical trial, that shouldn't be done. Yeah. And and the truth is that the combinations that have been approved, which are practically basically only in renal cell cancer, the immunotherapy works and the tyrosine kinase works. And then you combine two things that work and you get something that works a little better, right? But tyrosine kinase inhibitors haven't worked in adrenocortical cancer, and immunotherapy doesn't work very well unless you've got some reason for it. So we never have a case in oncology, never. There's never been a case where two inactive drugs all of a sudden magically showed activity. So you have to have some inkling that it's going to be beneficial to begin with. So there's a lot of that going on. I'm okay with it if it's being done in a clinical trial, but just on the side, no, we shouldn't do that. Shouldn't do that at all, because there's no data for it.
Right. And if I can make a comment and maybe just add in what Dr. Fojo say, I mean, I completely agree, because it's like this data came originally from kidney cancer, because like Dr. Fojo said, there was two drugs that work in renal cell carcinoma. So you put them together, it's like, well, it worked better. But that said, even in ACC, the patients, because there may be some patients that may respond maybe to TKI, but we know it's not the majority, and it's not a large number of patients that responds to that. And because of that, it's difficult to make the recommendations, whether, unless like Dr. Fojo says, in the setting of a clinical trial, we need those studies. And I know that there is a study with cabozantinib, and I know that there is ongoing studies, but unless we have that information that this drug is going to help, or not, it's very difficult for us to make the recommendations. And I know that some others, they say, well, because it worked in kidney cancer, we should do it here. But the reality is that we don't have that data. And even those that may respond to cabozantinib, may respond to chemotherapy, the percentage is quite small. So, and it's not like what we see with kidney cancer, that even with those therapies, we know the percentage that is a lot higher, that makes you like, okay, we're going to try this agent, but this is not what we have seen in ACC.
Yeah, and I tend to see that happen, and I think part of it is sometimes we try everything we can to help these patients, and we're trying to find whatever it is that we have at the moment. But in such a rare disease, that doesn't help us further the science, does it?
Right.
Right. I mean, I actually also believe in Dr. Rivero, Dr. Del Rivero knows this because I mentioned it to her. Once you get deep into a treatment, somebody who's had 2 or 3 treatments, I believe in using just one agent because the likelihood that one agent is going to work is very small because this is a difficult disease and these things don't work. The likelihood that you're going to get 2 agents that work, I mean, you're more likely to win the lottery than to have that happen. And 2 agents are always more toxic than 1. That is predictable. So then I prefer to try them one at a time and not confer as much toxicity with what I'm doing and have a chance to try them out. So
Yes, and if I could make a comment as well, I think I mean I absolutely agree in terms of this is a rare disease, and even in clinical trials, it's very difficult to recruit patients. But that's why I think collaborative efforts is important to study this tumor type, and also help each other. This is I have to say, and that's something that I mentioned earlier. It is true, and I stand by that. That when Dr. Fojo was here at the NIH, he basically wasn't one of anyone who kind of like said, "Well, let's do surgery for some patients, let's do ablation for these patients." I don't think before he started doing that, I don't think that was there for patients with ACC. So, and that's why I think that yes, I mean, some of the experts discussed earlier that it's important to discuss with different experts as well to understand what would be the best treatment algorithm for those patients, and knowing yes that this is something that we understand too, like this is sometimes we need more therapies for ACC. At the same time, I mean, I think that we're working to also develop better therapies. I know Dr. Fojo is working on that. We're also working in our side as well to develop better therapies for ACC. So I think I still want to feel I'm hopeful. So because that we're working on this, and we want to make sure that there are people that are fighting, to get better therapies for ACC. Dr. Kiseljak-Vassiliades, she's passionate about the work that she does, and I'm also learning from her, and the same with you, Dr. Hallanger. So I know that you're there for the patients, and I know that you want these patients to have the best quality of life. And because of that, the efforts that we're doing right now is something that can definitely help patients in the future as well.
Yeah, and I think that the benefit of being at the centers where the 3 of us are we can work and learn off the positive results that people are finding in other tumor types. I'm thinking about the future of cell therapy for solid tumors and having hope about that, and all the organoid work that you and Dr. Vassiliades are doing. I think those are very hopeful for all of us. So I think we've gone quite a bit over time. So I'm going to ask Amanda to.
I was just going to say one last thing, because I saw somebody asking whether you could ablate a bone lesion. So I didn't emphasize enough. That's where radiation therapy is very good in bones. So for whoever had that question, I wouldn't be looking to ablation. I'd be looking to a high-tech radiation therapist to give radiation therapy for that.
Very good.
Thank you so much, everyone.
Thank you.
So at this point, I am going to introduce Emerald Cromwell. She's going to say a few things. She actually did the interviews for the video earlier. And I'm going to pass it over to you, Em.
Hi, everyone. First of all, if you're still here and you've stuck through it through the day, thank you so much for joining us. It ran a little bit over, but I do think that all of the information that was given is just a wealth of knowledge. And I want to thank all the experts that have dedicated their time to doing this today, because I know that you could be out there doing better things. And I know that everyone here really, really appreciates it. So, dealing with this disease, we've given you so much of the medical knowledge, and we think it's important that obviously, I think we've shown why you should see an expert, why you should advocate for yourself, but there's so much of the emotional part, and it's a difficult disease to deal with. I'm so sorry because I just found out about my third recurrence this week. So I have to say that everybody here on this group, I couldn't do it without you. I feel blessed to be in the presence of all these experts and having them under my care. I have this amazing group from the support group that cheers me on and tells me that I'm okay. My husband just walked in and told me I'm okay. So with that being said, Jennifer Jeffries-Wright is going to tell her story. She's amazing. Please hang on and listen to it. She is a 28-year survivor of stage 4 adrenal cancer. I'm going to let her tell her story, but Jen is the one. Hey there, girl.
Hey.
She's the one that I reach out to whenever I'm scared, and she has been my cheerleader and helped me through all of this. So I want to thank you, and I'm going to continue doing these interviews and play them in their entirety on the ACC channel. I think it benefited me, and I think it'll benefit others. So I just kind of want to put that out there too, as much as that I can and will be able to do with my upcoming treatment. I'm going to continue those interviews. So I'm going to pass it over to Jen and let her tell her incredible story. And thank you, everybody.
All right. Well, like Emerald said, she had asked me to kind of tell my story and explain to you guys why it's important to advocate for yourself. So I started my journey in 1995. I wasn't really diagnosed with adrenal cancer. At first, I was told that I had Cushing syndrome. That was what I was told. I had just had my son Patrick, and I was 19 years old, and he was a beautiful 8-pound, 9-ounce baby. But during my pregnancy, I put on a lot of weight, and it wasn't from eating. I didn't overeat. I didn't do any of that stuff. I did the walking. I did everything I was supposed to do. And it didn't run in my family to become obese. So I had been going to the gym after I gave birth to him, and I'd gained like almost 70 pounds during my pregnancy. So I was trying to get rid of the weight and everything, and I could not get rid of the weight. So after hiring a personal fitness trainer and doing everything that I could, to lose the weight, I started going to the doctors. And while I was going to the doctors, I got lectured on the proper portion of a piece of meat being the size of your fist or a plain deck of cards. And it just was constantly belittling me and telling me that I was eating too much food. So after several months of this, I was finally listened to, and we started doing some blood work and some testing. And I did a dexamethasone suppression test, went to get some CAT scans done, and we found out that I had a grapefruit-sized tumor on my left adrenal gland. So I ended up I lived in the state of Oklahoma, and I went to the biggest premier hospital here, OU Medical Center, and I ended up having the chief of surgery because they'd never seen an adrenal tumor like this. And he did perform my surgery. I was supposed to be getting elite treatment. And so he wanted to do this, and I thought I was under the best of hands. And he took out my tumor and told me that that it was Cushing syndrome, told me to go on prednisone, that I needed to get pregnant again to kickstart my right adrenal gland because this was my left one. And so he had removed my left adrenal gland and this grapefruit-sized tumor. And so I thought everything was good, and I just had to be on prednisone for a little while, and that getting pregnant again was going to be a good thing for me. And so I followed doctor's orders, went home, planned a pregnancy about 10, 12 months later. So my kids were only going to be 2 years apart. I was in college. My husband and I thought everything was going to be great. We'd have kids 2 years apart. Got pregnant again. Was still thinking everything was going to go okay. During my pregnancy with my daughter, had a lot of complications. And during that pregnancy, I was told they thought she had Down syndrome. And they wanted me to get my amniotic fluid tested during that time. And if I would have gone and got my amniotic fluid tested, they probably would have realized I had cancer, but I didn't because that was just to terminate the pregnancy, which I wouldn't have done. So hindsight, that would have been my tumors casting shadows on my daughter's femur bone. But long story short, I went through with the pregnancy. When my daughter was 4 months old, I went back to the doctors because I couldn't lose the weight, and told them I thought I had Cushing's syndrome again. Again, I got lectured on a proper size portion of a piece of meat. And I went back to my personal fitness trainer, and he demanded that I call my doctor with him. And so my personal fitness trainer called the doctor's office and told them that there was something wrong with me, and that if they didn't do the tests, that he was going to sue them, and he was going to call all these people. So my doctors brought me back in. This time they accused me of not taking the pill for the dexamethasone test because the test came back so high. Once I told them I promised I took the pill, they ordered CAT scans. And when I had my CAT scans done, I knew the way the nurse helped me up off the table that day that there was something wrong. So when I went home, my phone rang before I, could answer it. The doctor wanted me to come right back. And I said, he asked me if I was home alone. I told him I didn't have a car to come back because my husband was at school. And he said, well, when will your husband be home? And I said, just go ahead and tell me. And the doctor's like, well, I don't want to tell you if you're home by yourself. And I was like, no, I already know there's something wrong. Just tell me. And so he told me that I had stage 4 adrenal cancer. And I said, what does that mean? And he said, it means you just have a couple months to live. And he told me that it was throughout my abdomen and throughout my lungs, like in the bottoms of my lungs, and that it was not survivable. And so at this point, my daughter was 4 months old and my son was 2. And he basically just said there was nothing that they could do for me. And I told him that wasn't good enough and that I needed to see an oncologist. So he made an appointment for me to go to an oncologist here in Norman, Oklahoma. I did that a couple days later. So my daughter, or my sister and my husband went with me to the oncologist. When we went to the oncologist here in Norman told me that there was nothing she could do for us, that I wasn't a surgery candidate, and basically just told me, it was too bad. I asked her if she'd ever seen anybody else with this type of cancer. Mind you, this is 1997. And she said that she had. And I asked her what they did. And she said she got on the back of her husband's Harley and rode off into the sunset. And she just suggested that I get all my stuff in order with my life. And I told her, well, that wasn't going to work for me because I had a 2-year-old and a 4-month-old, and that we wouldn't all fit on a Harley. So she said she was sorry, and she walked out the door. And so at that point, my husband tried to get me to leave with him. And I just sat on that table, on the, little table that the doctor sees you on. And I said, no, I want to live. I don't want to do this. I'm not going to accept it. And my husband walked out on me that day. And he went and he got in the car and he left. And my sister sat with me. And she said, okay, Jen, what do you want to do? And I said, I want to fight. And so I sat in that room and I waited and I waited and I waited. And the nurse came in to clean up the room so they could see the next patient. And I was like, she said, are you going to leave? And I said, no, I'm waiting for the doctor to come back because she hasn't seen me yet. And she said, no, she said she came in here. And I said, no, she hasn't taken care of me yet. I need some options. The only option she gave me was a Harley, and that's not going to work. And so this went on for about 45 minutes to another hour. And so the doctor kind of was huffing and puffing. So she finally came back in and she brought me these protocols. They were printed documents. And these documents were like research protocols. One was MD Anderson. One was the Mayo Clinic. One was someplace I had never heard of. And one of them was NIH. And as she started reading them all to me, she was throwing them at my feet and telling me that I didn't qualify. Every one of them was not about adrenal cancer. There was some other weird cancer that I'd never heard of. So the last one that she got to was NIH. And she told me I didn't qualify because the tumor was supposed to be the primary tumor. And obviously I'd already had my primary tumor removed. But she said that it was my last option. She said she would make the phone call to NIH and send over the referral, but the rest was up to me. And she shoved the paper in my chest and she said, now please leave my room so that I can see patients I can actually help. And so I said, okay. And so my sister and I left and I went home and I called NIH that day. And that became the story of my journey to going to see Dr. Fojo. It was a tough journey. It was hard. Not going to lie. I went through the rest of the money that I had, but I got on a plane and I flew out to NIH. My granny went with me. My husband went with me, and I spent about 12 years, I guess, going back and forth to NIH. I had 13 surgeries over the course of this time. I did, I guess, 8 abdominal and 5 lung. I did 3 RFAs. I did a ton of chemo. I don't even remember how many. 28 pills of mitotane a day is what I got up to. But, I lost a lot of friends. We all we were the OG of the time, I'd call ourselves. But Dr. Fojo, I remember it almost felt like he was trying to talk me out of joining the protocol when I did it. But he's definitely the one that tells you how it's going to be. And, but he prolonged my life, and I've been NED now for 17 years in May, and I get to live my life, and I'm enjoying my life. And my son is 27 and my daughter's 25. And my last surgery was in 2006. And when I had my last surgery in 2006, I also filed for divorce. And I lost a 180-pound tumor that day, and my cancer went away. So not only did I learn during my battle with cancer to advocate for myself and to, stick up for yourself with doctors, I also learned to advocate for myself with people. So I'm in sales, and that's what has been my career. I learned to stick up for myself, to fight for myself. I don't have yearly scans. I listen to my body. I know some people think you have to have a scan every year, but I don't. I do pay attention to my body. I know if I was to gain a bunch of weight or things like that, I would go to the doctor. I felt like I got hit with the ugly stick when I got adrenal cancer because I did have the hormone producing with cortisol. So, but I do want you guys to know, if you have a doctor that treats you like that, if you have a doctor that thinks they know everything, if you have a doctor that says, they've never treated somebody with adrenal cancer, or they've only seen one person, run. Go to NIH, go to one of these doctors that was on today talking to you guys. These are the people that you need to be with. These are the doctors that know everything. You'll see my chest is getting red. I'm really passionate about this, but Dr. Fojo is my hero. He'll probably tell you I was the biggest pain in his butt, and I was, but he saved my life. And I don't know. I've lost a lot of friends. I'm doing this today for Emerald. So I'm doing this today for John, for Marie, for Philip, for a lot of people. And I live my life every day for the people that have gone before me. And you guys might not like everything I say when I tell you guys, you don't have to have a scan every day, or I tell you guys stuff that I've learned, but I was doing this before Google. I did this before Facebook. I did this the hard way. I'm not saying it's easy now. It's not. But you guys have all these groups. You have amazing doctors. You guys just keep fighting. Don't give up. they've learned a lot since when I started. And just be your biggest advocate. If somebody's not fighting for you, fight for yourself, and, kick the people to the curb that don't fight for you. I'm not advocating for divorce, but get rid of the people that don't stand beside you and fight with you. So just keep up fighting. So that's all I have to say. And don't lose hope. Okay? So.
Thank you. You made me cry.
All
But
right.
thank you. That was needed. Thank you. So I am going to introduce now Shannon and Jolene, who have helped put this together. So I'm gonna let them have the floor, and they'll give closing remarks, and we will be good.
Hi, everybody. I want to keep this brief because I know that we've been on for quite some time now. I just want to say thank you to the amazing doctors who helped make this conference possible. Thank you to Jennifer Wright. Your story is the one that sticks with me the most. You're an inspiration to every ACC patient. I think of you often, and you give me hope every single day. Thank you to all the patients, family members, and caregivers who have taken the time to watch this. We hope that this has proved to be informative, that some of your questions have been answered, and that it has even helped you formulate some questions for you to even ask your own providers. The ACC community may be small, but we are mighty, and we take care of each other. You're not alone in this battle. I know there's a bunch of people that have been newly diagnosed, and I just want to say, don't give up. Advocate for yourself and just keep fighting. For those of you that would like even more information, Dr. Del Rivero will be participating in another conference on Tuesday, January 31st, 11 a.m. Eastern Standard Time. The conference is on the early and optimal management of ACC. They will be presenting real-life scenarios, and we'll have discussions on the best approaches and management of these specific cases. We will be posting this information on all the Facebook support sites shortly. We didn't want to post it too soon, just with this conference coming up, but we will be fiercely promoting that one next. And again, just thank you to everybody, and feel free to reach out to any of us if you ever have any questions, if you need help advocating. Some of us have been doing this for a long time, and we just want to help.
In closing, I'd like to add that on behalf of ACC Connections, we would like to thank all of the doctors that participated today, our adrenal cancer expert doctors, Dr. Del Rivero, Dr. Fojo, Kelly from HRA Pharma, Jennifer Jeffries-Wright, and all of the patients in our opening segment for taking the time to participate in our conference today. A lot of great information was shared with our patients, and we thank you all so very, very much. I'd also like to thank Dr. Del Rivero for being the inspiration to help us put this conference together, for all of her hard work behind the scenes, and for her sincere and tireless dedication to all adrenal cancer patients that she sees from all over the world. I'd also like to thank Amanda, Emerald, Pat, and Shannon of ACC Connections for their tireless work in making this conference happen. You all are true friends that inspire me every single day. Lastly, I'd like to thank you, the patients, your families, your friends for joining us today. I was diagnosed almost 10 years ago, and I so wish something like this was available back then during the most frightening time of my life. In closing, I'd like us all to remember, there are a lot of statistics online for adrenal cancer, and it can be very scary to read. But we, the patients, we are the real-time statistics. Because this cancer is so rare, it affects only 1 in a million. So most of our local doctors and surgeons don't know much about it, if anything. That is why I implore you to see one of the adrenal cancer experts. Be your own best advocate. We only have one life to live.
do everything you can for yours because you are worth it. Thank you once again for joining us today.